If what?
They're gonna look
Like the seconds?
Okay.
Yeah.
One student who's at a local hospital, that's not told him about this. I'm not gonna tell you which hospital it's at. You what it was. And how to use it. They have a magnetic device. When they're having seizures, they pass it over it. And what it's supposed to do is reduce the seizures.
So it's kind of like an ICD. Well, no, you turn that off with the neck, right?
The MRI will turn it off. You cannot turn off internal defibrillator. Okay? You can't reset it. You can't turn it on. Okay? But this, you can pass a magnet over. What it does is reduce seizures. Okay? They have to have it on them at all times. And the student was at a hospital, and nurses didn't even know what it was. Yes.
My sister has one.
Your sister has one. A lot of patients, okay, I'm sorry. A lot of patients have those. It takes about a year to see if it's going to work. So they have this device in for a long time before they know that it's working. But if I have a patient having seizures and I know they have it, and you got to carry an ID card, right? So you work in the emergency room, and this is where it happened in the emergency room. And the student knew to take the magnet and wave it over the device. Nurses didn't know it because they had not been exposed to it. And what it's supposed to do, I don't know, does it stop your sister's seizures?
It helps a lot.
It helps a lot, yeah. It won't. Sometimes it just keeps her from being so prolonged, or just keep her from having so many different ones.
Better off with it now than she was before.
Yeah, yeah. A lot of patients have them out there. If you don't know it exists, all I did was show you how they put it in. This is the neck, and it's wrapped around the vagus nerve, and then the device is implanted in the chest. Okay? This is why you got to check for what when the patients come in? What? What? ID cards. You need to check. A lot of folks out there got devices in, guys, and that's why a lot of the history says, do you have any type of internal device? Don't be precarious when you ask that question, okay? Because they're robotic. You got a lot of stuff implanted now.
Is that device visible like the pacemakers and stuff?
Yeah, it can look like a pacemaker if you don't know what it is. So whenever you find something that looks like a pacemaker, you ask questions because it may not be a pacemaker. We make the assumption that it's a pacemaker when it actually may be one of these devices. I'm trying to find spinal cord injury. I do want to talk to this. I didn't have my pictures before. I probably don't have them now. That would just be something I want to do. I can just talk because you got 20. How many points? 15. This is a CT scan of a patient with a open head injury. He was gunshot. Can you see the bullet? Okay. Right here. And it probably came out somewhere. That may be the exit. I don't know. Okay. But I want to talk to you about one type of head injury that we did not discuss. Got it? Okay. And it is called Did you see that in your readings?
Yes.
Okay, do you know what the basis for fracture is? Right? The what?
Recognize.
Okay. I took all of that off the test. I took it all off the test. I should have left it on there, shouldn't I? It's still on there. Trust me, it's still on there.
That's the process.
Okay. I want you to get these 25 points before I can read this.
We do too.
Before I go to spinal cord injury. A basal skull fracture, a lot of patients get. And you saw that picture, just means the base of the skull, the integrity of it is altered. Okay? And what happens with that is cerebrospinal fluid will leak from the central nervous system. Now, where will it leak to? Nose, ears, okay? He's unconscious. Yet, they'll come to you walking and talking. They'll walk to the hospital sometimes. So you gotta use your assessment skills. But I give the scenario, you have a 25-year-old who hit a tree in an accident and he's intoxicated. Being intoxicated does not make you not assess patients and give you knowledge. You know that, right? And he's sitting on the table and his nose is running. And he keeps wiping his nose. Constantly. You see test questions dealing with that. And you look and he's got some clear snot coming out of his nose. What the test questions say may appear to be mucus. Put two and two together. Head injury. He could have a basal skull fracture. Okay? So what do you do with it?
Check for glucose and halo ring.
You check it for glucose or halo ring. Now how do you check for halo ring?
On the
Put a
paper.
drop on a 4x4 and look for a yellow ring that occurs around it. Okay? Now my test question was always very lofty because it can be pink tinge or yellow. When you lock yourself into the book, and you know what students always answer? They hemorrhage you. Because it's pink tinge. Okay? When it was a basal skull fracture. Nothing comes black and white. You got to use your assessment skills and your critical thinking. Okay? So that halo is a sign of a basal skull fracture, as well as the glucose check. Why is it that you can check the glucose in cerebrospinal fluid and know that it's cerebrospinal fluid?
Because it's less than 50%.
Okay. What did you say, Monica?
Because their insulin has to be 50 to 70.
Yes. In the cerebrospinal fluid. Okay. The brain likes oxygen, glucose. Do what? Glucose is sugar. Yeah. So it thrives on that, and that's why it's so high. Okay. Not all basal skull fractures will die. The ones I've had in the past, I don't have very good memories of a basal skull fracture that walked away because the brains were actually oozing out of the ears as well. And those patients didn't make it. Okay, this is stuff I had to experience. I was talking to a friend of mine, and he said, "Why aren't you crazy?" I said, "I am." I used to work in the field. I'm not really crazy, it's just that you get immune to stuff after a while. Not immune, but you learn to deal with it and you go on. If you want to work emergency nursing, that's what you have to do. But yeah, if it's a patient like this patient who has a basal skull fracture, leaking, and you did the halo test and it's positive and it's got glucose in it, okay? What is this patient at risk for? Meningitis. That's what the book says. Why?
Because it's exposed to the light.
Okay. The integrity of the skull has been exposed to the nasopharyngeal area, which is full of bugs. So that person is going to end up with meningitis. Okay. What are some signs of meningitis?
Fever, mucosity.
Mucosity. That's the way you get it, okay? If you didn't remember that from pediatrics, it was the only one with mucosity. Okay. All right. So anyway, I'm going to start spinal cord injury. You should remember that from pediatrics. I can't teach you everything new. Okay. However, you know why you guys don't get questions I give you? You always thinking I'm just talking about what I'm teaching. I keep warning you, don't think that way in this class. Let your knowledge flow. Somebody said, I wanted to make sure that pump was on 80 because we can't put it any higher than 80 on ICP. All I wanted you to do was walk in a room like you've been doing since you've been in this program and look and see what's wrong with that patient's room. I have found IV stopped up with students. I have found the IV bags empty with students. Okay? I have found, now this one was very bad. Nobody really got it.
Hyperextension of the
And D2 was out.
I thought that was take here.
See that tape right there?
I thought it was just more
See
tape.
that
I thought it was secured.
That tape is where you measure the tube and you push it down to that tape. Remember nose down?
Yeah, but it is.
Okay.
I thought it was to
And
go
that's
around.
how you would do that, that's why there's a lot wrong with this. But I'm gonna tell you that actually happened with a student. And I walked in the room and the patient was swallowing. The nurses had missed it all day. That patient had already aspirated. And when I walked in the room, I saw that tape hanging way down here. Student had already gotten the patient's vital signs. Senior student. And I went in and I immediately cut the pump off and started suctioning him. That tube was out. How did I know it? Because I saw the tape hanging down. It slipped through all of his fingers. And when we give you a U, I'll let you know that, okay, Dr. Rainer, just give it to me. I had a student tell me, he came out and said, just give me a U. I goofed up. Now you learn from it because you're not going to fail, because you don't have to repeat some stuff. So the bag hanging on the railing, that should have been obvious. Okay. What else did you find with this video? Head of the bed. Somebody said because he was a head injury. Tube feeding. Even if he wasn't a head injury, that leg should not have been flat because he has what? A tube feeding going. So the head of the bed should have been elevated. Got it? He had a peak line in. I didn't do anything with the peak line, okay? Except for the tube was coming across his bed to the lung. That's it. You know how many times I find that? Patient pulled the IV out because the tubing was running across the bed.
I didn't see the blood pressure cut.
It's one on there.
I wanted you to snapshot what you were seeing. And you snapshot trying to treat a head injury. You see the difference? You're compartmentalizing your knowledge. That's why you have a little bit of problems. All you thought about was a head injury. That was it.
What about the suction when it's hooked up?
Yes. But it was on this side of the bed. It was hooked up on the other side. And that's good because the patient couldn't manage the airway. Okay. I walked in rooms, real world, with students, patient unconscious with a feeding tube. They didn't think to put suction in them. And I'm not beating you up. I'm just showing you how to be nurses. Don't compare. When you walk in your room, you should be seeing some things. See that IV bag? Flat is dead, patient. And I always tell students, when do you change your IV bag? Before it gets empty? There's a rule for that, okay?
Well, yeah, but I mean, when it's.
When do you change your IV bag? When do you change it? Give me theory. Don't give me idiosyncrasy. Give me what you learned. I don't want to hear that. Give me theory. I don't want to hear any of that. Because you have to go by knowledge. Okay? When you say a nurse said, I want to hear that. I want to hear what you say because you're going to doing practice. So when would you hang your IV back? That's NCLEX type questions. You know that, right? What did you say, Tammy? I heard you saying something. Before it runs out?
Yeah, like with 50 to 100 left.
Good. Your last 100 milliliters. And that depends on if it has medication in. Now tell me what the nurse said.
We just program it like if it's got 1,000 milliliters, we program the pump at 900.
Yeah.
So it'll go
Same principle. Because I want to know what you want, what you know. Because nurses will tell you something just, and they'll walk on and say, I have to tell them something. They ask a question, I have to tell them something. It may not be right. I want you to start using your own knowledge and theory. Okay, let's do a little bit of spinal cord injury before you take the quiz, because I got to move on further. Okay? All right. And then you can take your what? Your, it's not a quiz, no, it's that's added to it. Yeah. I don't lie, when I say I'm gonna do something, I do it.
Group test.
Group test for 15 points, that's pretty good. I wish I could stop spinning. Okay, here's the spinal cord. You have cervical C1 to C7. There were a few questions that said something about C7. Now, those were not spinal cord injury questions. None of them were. They were basic nursing information. Like if they got their home in town, what do you do? That's it. I can't teach you. I can only take that patient and put them in what you already know. That's what you do, okay? And the reason why anybody who's immobilized with a head injury and they're unconscious, I got to go back to the hazards of immobility and airway. It doesn't matter, okay? Some things just doesn't matter. You're going to do that for all your patients, right? All patients who can't move on their own, what do? Skin management, airway management, turning, coughing, deep. You see where I'm going with that? Okay, there's a few things you learn because you can't make a ICP cough, but they can deep breathe. Okay? All right, so you got C1 through C7, which is up here, right? And then you got T1 to T12. Most of your accidents with spinal cord injury is going to be there. Why? Whiplash. Who said whiplash? Oh my gosh. Don't say whiplash. The what? Is not supporting. That's it. You may like that. But you're right. We do get whiplash there because it's not supporting.
That's what I meant, like the head
Between
goes back and
C1 and
forth
C7.
whenever you're in an accident.
Yeah, exactly. And you get injury in this right here. Okay? So I still can't do the role play because I don't have my equipment. But maybe I can. Maybe I can. Do I? Maybe I can. Okay, so whenever you got a spinal cord injury, you have to worry about the integrity of that cord. Because if it's fractured here and you don't do the right things to that patient, it can go all the way through that cord, and what they ended up with is what? Paralysis for sure. Okay? And that's all that said. You probably have these notes. I don't remember. Okay. Who wants to answer that? You may have that one too. Patient entered the ER with a spinal cord injury at level T2, yeah. Which of the following find is more of a concern for the nurse? More of a concern for the nurse.
B.
Heart rate 20.
Yeah, B.
I'll say A.
A SpO2 of 95?
C, because the pressure,
What
right?
is
Is it C? Because of the,
So why is it C?
because of pressure, because it indicate shock, maybe? I don't know. That's when blood pressure goes down and heart rate goes up. Yeah. It could indicate bleeding, but it's C2.
If you decrease
It's
the
not-
blood pressure, C is the answer. If you decrease the blood pressure, you don't get blood supply to the cord, any of your organs. So you got more further damage. A low blood pressure means low what? Perfusion. You need to remember that because I'm getting ready to go into multi-organ system dysfunction. Low blood pressure means what?
Low O2.
Low perfusion. Okay? So that blood pressure is very significant. Okay. There's upper molar neuron and lower molar neuron, and I'm not going to go to your book with that. Okay. Your upper molar neuron is
Spasticity.
spasticity. That's what you need to remember, and you can put it in your notes. Okay. They have spasticity.
Dr. Jane, can you repeat that, please?
They are spastic.
On the upper?
It's in your book somewhere, I can't remember what page. That's the only thing I require that you remember. Because when a patient has a spinal cord injury, it's there, it's done. Okay, whether it's upper motor neuron, low, it gets very, very lofty. But if you know that person is going to be spastic. Have you ever seen a patient with spinal cord injury?
Yes, ma'am. I had one.
Was he spastic?
Oh, yes,
They
ma'am.
all are spastic, just about. You know who's spastic? The lower motor neuron is sort of like your CVA patient. Most of your spinal cord injuries, they can be lying there and you pass the bed and what happened? And then she said, you thought he had a seizure, didn't you?
I did. Yeah, she did. That's why I laughed. She was like, what's wrong? I was like, oh, he is fast.
Knowledge will make you look more intelligent. Not knowing will make you look what?
Oh, I ain't saying nothing.
When in doubt, keep your mouth closed. That makes you smart. And know when you don't know. But it will scare you because you think they are having a seizure, but they're spastic. And that's an upper motor neuron damage. However, those are the patients that you expect to be on what kind of medications?
Baclofen.
Which is your antispasmodics. Okay? And I have to go pretty fast, so I'm not going to be able to role play a little bit. I don't know. We'll see. I want to get through this so you get your 15 points. You feel like you need them?
Yes.
You do?
Yes. Thank you.
Transit concussion, you can have a contusion, laceration of the spinal cord, compression of the spinal cord. The extent of damage can be complete versus incomplete, okay? In essence, the spinal cord can be jolted, concussion just like the brain, or contusion, can have some bleeding and damage to it, and then it can be torn, okay? It can be torn. And with that being said, okay, I had this on something that student didn't get it. I think it was a 1 point or something, but they never get those either. The neurological level, the lowest level is which sensory and motor functions are normal. Crystal, we have a 25-year-old spinal cord. Why do I keep saying 25-year-old?
Because those are going to be a vaccine.
Okay, young males. Young males. And you have a young male who came in who ran into a tree and has possible spinal cord injury. They have a C-collar on him, and they have a backboard, because we still use it as a backboard, okay? You know not to take him off of there until the x-rays have been done, okay? Now, you got to assess him, so you did his vital signs, make sure he was breathing. Now you want to know, does he have any level of injury? What type of test would you do? Two-point discrimination, great. What else did you do?
Not that one.
What else did you do?
The grasping up my hand.
For the upper cord? That checks for strength now, not for sensory.
Is it at the CA?
Yes. Is the Babinski conscious or unconscious?
Oh, unconscious. Never mind.
No, you answered it right, and then you debating your own self.
Well, you look at me crazy.
No, I look at you crazy because students miss that. They miss that on my test. The Babinski is unconscious.
Okay.
It's going to do what it does whether the patient is out of it or awake or whatever. You can't fake the Babinski.
Right.
You may fake some of the sensory if they're watching you do it.
Okay.
Okay? So you're doing the two-point discrimination up the leg, or you're doing sharp dull, and he doesn't feel anything until he gets about here. So now you can tell the doctor where his level of injury is probably at, is below what? The knee, he has no sensation. So you have to do that test to decide. And she's going to do the Babinski, right? And what do you expect his toes to do? They would do what?
A&M.
Okay. That's a positive Levinsky. What's a negative Levinsky? That's good. You remember it from health assessment. Excellent. So his toes did that. And you did dull shock, you did 2-point discrimination, no sensation from the knee down. With a positive Levinsky. Pretty much he's got some spinal cord involvement. It's not good, is it? These are some reasons for spinal cord injury, and that will beat you up. But that 25-year-old, pick a tree, he was not wearing his seatbelt, and he has spinal cord injury, and he has a very bad fracture at C5. I should make it a little bit lower. Let's do C7, because I'm thinking about his level of sensation. Okay. Got it? So, you have him in the emergency room with a C collar on the backboard, and he has C7 thigh x-ray. We did a C-arm x-ray. We know that is right. C-arm. Remember the x-ray? C-arm? An x-ray, that's what we saw. Okay. All of a sudden, his blood pressure starts dropping. And his heart rate goes down to 45. And his respiration is 16. Spinal shock. What are you going to do? First of all, tell me why he's gone into shock. You better not say bleeding. You better not say it, because there's different types of shock. Why is he going into spinal shock? Because if you don't know the origin of each one of these shocks, you're going to mistreat them. I.e., cardiogenic shock. Do you give fluid bolus? No. No, you're going to kill them, okay? You try to get something to get the blood pressure up, because the heart can't handle all of that fluid bolus. So you got to know why the patient is in shock. What's causing the shock? Did you read it? No, you didn't. Do what, Thomas?
It's response to the injury. It's response to the injury.
Okay, it's a neurological response to your nerves. Okay, your nerves innervate your adrenergics, okay, which causes your vessels to constrict. They don't have that. So the blood pressure will drop, okay? So he's in what? Spinal shock. That is not good, okay? Now, he has the primary injury. He goes into spinal shock, and we got to work on the secondary injury, okay? And that can be swelling. Usually it's swelling. It may be reversed in 4 to 6 hours after the injury if fast and effective treatment is done, okay? So whenever we're looking at secondary, just think about inflammation is developing that's causing more swelling, that's causing that cord to get less blood, right? So you have more spinal cord damage. So what do you want to do for this patient? Steroids? Okay. What time frame do you have to get it in? How many hours do you have
4 to 6 hours.
before you have to get the steroids in? And that's what I'm looking at here. The first 72 hours you got to do. Within the first 72 hours. Don't wait 3 days. You want to get them in by then, okay? We usually do 24 hours. I'm sorry, that's wrong. That's wrong. I was thinking about something else. It's the first 8 hours. Not 72. That's my mistake, I'm sorry. Yeah, first 8 hours. And it should be in your book, not 72. That's too late, isn't it? All right, so we're going to start corticosteroids. And he's in spinal shock, which means what? His blood pressure is down. Got it? All right, now I want to back up to the emergency scene. I do not have a sea collar. However, Kristen said he would be the patient. So you want to be the patient, Kristen?
Sure.
Who wants to move Kristen for me?
Maybe if you want to.
You want us to volunteer?
I don't care if you volunteer.
Somebody get pictures.
I don't know about that, but let me go get one thing that I'm going to need for you for them to move you, okay? Would you put 2 chairs together for me? 3. Take 5 minutes. You thought he was lucky because he was skinny, but he's tall. Y'all did good. Now, when he was lying on there, would you elevate his head because he has a head injury? No? Okay. That's what I'm saying, because he possibly have a hand injury, a spinal cord injury. If he's on backboard, you can still tilt the head. You can tilt it, because you can do the whole bed. But I would not elevate the head. The only time we do that is when we really show them have to, and we don't use this cranking up. What do? There's a pedal you hit on your stretcher, and it'll do them like this, and keep them straight.
So, with that, was it okay for them to move my head how they did?
But they had to.
There wasn't no other
They
way
had
to
to
do
get
it.
it on.
His head was like that.
Yeah, they had to. And they move, I saw them moving it. They kept it in midline. They moved it very, very carefully. You don't want to move it at all, but however, sometimes you have to do what you have to do. But you have to do it for the best patient situation outcome for that patient. So they did move it, but they kept, if they were flipping it around and turning it, trying to get it on, you notice she never did that. She just raised her head up off the floor to get the seat collar on. She didn't twist it in any way. Because twisting your head is twisting your spine. And if you may have a minor spinal cord injury. Once you move that head, guess what? Went all the way through.
Dr. James, did you say that you would elevate the head?
Leave that alone. Leave her flat.
Okay.
Leave them flat. Because I hung up a thing called rapid responders. You guys, if you don't know, can't see the whole picture, know what equipment does in the hospital and all, you're gonna make a mistake. Okay. And I was telling Mrs. Mack, I have to keep remembering entry level. And she said to me, but entry level is harder now. And that's true. So maybe I need to back up. Your tables will tilt all the way without raising the head like this.
Correct.
And keep the spine straight.
Okay, but that's the most important thing until they have been checked out is keeping
That
the
spine straight.
Straight, okay.
Yes, that's it, you got it. Okay, the goal is not to do what? The goal is not to, is management to prevent further spinal cord injury and detect the progression of neurological damage. If conscious, complain of pain, which may radiate along a nerve. What if Question was conscious and he said to you, my neck is broken? He has no x-ray. What you believe in?
Yeah,
You would assume.
Let me tell you guys something. If a patient tells you, I believe my neck is broken, you better believe them.
We would say, so I understand that you have a fear of having a broken neck.
I knew it was coming. I'm trying to give y'all these 15 points, that's all I'm trying to do. If a patient tells you it feels like the neck is broken, then you have to believe it. Okay?
What did you say?
And I will treat them like a spinal cord injury right away. They may have pain or they may not have pain. They speak or fear that the neck and back is broken. Believe them, okay? Respiratory compromise depends on the level of injury. So the first thing she did was check his breathing. I think some of y'all are getting that now. It doesn't matter what's going on. If they ain't breathing, it doesn't matter. I think some of y'all are getting that now, okay? This is real world. I don't care if the leg is broken, they got a compound fracture with the leg sticking up to the sky. Okay, you got to deal with that. Okay? But if they ain't breathing, you down there fixing the leg, ain't no so, you know, keep it prioritized. So she did do that. Okay, what if Question had very erratic respirations? They slow up and speed up. Maybe he goes through apnea for a while, and then he starts to breathe a little bit. He has changed strokes. He's just doing some of everything. It's going to be a high up. It's going to be a high up because that C5, those nerves come out of innervating the diaphragm. Okay, so the higher up, you're going to lose your diaphragm. And that's why I gave the other person a C7. If you go to C5, you might as well get what ready.
Intubation.
Intubation and ventilator, because they have nothing to make their diaphragm work. Okay. Can you continue to treat from the scene, backboard, collar, etc. So when I came in, these guys did a really good job on him. Okay. They worked together as a unit. They knew that she had the hands, so nobody else give command. Shut your mouth. Okay. I don't care, unless she does something wrong now, then say something. But as long as that person that has that head is doing what they're supposed to do, too many voices will mix up a situation. Okay? Too many voices will mess it up. So that person gave command, okay? I walked in, I'm going to continue, well, me as a nurse, not as a wife. Because I'm sure y'all wouldn't let the wife back in, would you?
You must be in jail now.
No, they didn't catch me. I went and got me a gun.
Oh, okay. That's why
No, I'm not gonna share
I'm
this.
gonna push you up against the wall until I have a long day.
Don't try that now. Don't try it. They didn't have Spice then. The guy was only on alcohol. Spice now, they don't care. I wouldn't try that now.
Doctor, what do you mean by that due to venous swelling loading may be extended initially?
Exactly. I'm glad you read that. It's supposed to be due to DUE, not DO, okay? Due to a deeper swelling, a lower injury may be extended initially. So what that means is the primary injury was when he fell and he broke that C5 and it stuck in that spinal cord a little bit and started a little bit. Now he has swelling around the C5. He has swelling around C5 and it's swollen all up here. So where is he at now?
Okay. So when the swelling go down, the initial injury is going to be.
Right.
Okay.
Right. You won't know what it is initially. Okay? So continue treatment from the scene, backboard collar, admit to emergency room, ABCs, neurological assessment, sets for other injuries, cardiac monitoring. The two disciplines they're going to go into is bradycardia and asystole, which is spinal cord injury. Okay? Remember that test question I had earlier, and some of y'all picked a heart rate because it was bradycardia? you can expect bradycardia on a patient with spinal cord injury. Okay?
Why is that?
It's just having to do with the nerves involved in the sympathetic nervous system loss, pretty much. Okay? Yes.
Is it because it stops signaling the SA node and the AV takes over?
No, not really. Not really. Because you're talking about another kind of rhythm. You still got the sinus rhythm. You still got the SA node, AV. The sinus rhythm is there, it's just a slower heart rate. You lost your sympathetic, is what you've done. The sympathetic keeps the heart rate up. So anyway, bradycardia and asystole are common in acute spinal cord. So you got him on a monitor, right? We put him on a cardiac monitor. Okay, what if he went into like a bradycardia of 20? Atropine, see? Atropine, that's what we do. We can't fix people on the spot. All we do is fix what they're going to do. How do we know what they're going to do? How do we know? We don't know. We do not know what a patient will do. So you got to be prepared to do what? Whatever. Okay? We don't know. He may or may not. Okay? Anyway, MRI, X-ray, myelogram, that's going to be a little later, but we are going to do initial X-ray, and we got a spinal cord injury. Okay? Now we're dealing with primary injury, right? We don't want the secondary injury, but it does happen. And what is the medication we're going to give for that? What is it? Corticosteroids, okay? Corticosteroids. Cannot classify spinal cord injury accurately until what is resolved? Spinal shock. Cannot. So what if the family came in and said, you know, I've been trying to get him to leave that crazy woman and he wasn't talking about he in love. Now my brother is paralyzed from the waist down. Well, from the mid-thigh down. And he's going to be like this for the rest of his life. And then all of them fall out and start kicking in the floor. You have family that does that?
Probably my mama's side.
Everybody got those in their family. I mean, they're going to just proper queens and kings, okay? So they start and they said, you know, my brother is going to be paralyzed for the rest of his life. What would you tell him?
Well, we don't know.
the injury to the swelling?
But we're gonna see after the swelling goes down what all will be affected.
You seem concerned about what the doctor has told you.
You know what she gonna say? Double H-E double hockey stick? Yes. I can't say bad word, but yes. And they probably will cuss you out at that point. I'm telling you, because they're in the answer, they're looking for you. Seem like you're concerned about what the doctor said. No, well, if there's no better choice, you pick that one, okay? You gotta look at the choices that are there. I can't give you a magic bullet, okay? If the choice is there and that's the only good choice, then you pick it, because you can't write in your own answers. But the better choice would be to tell them what? He is experiencing what? Spinal shock. We do not know what's going to happen until that resolves. And then you got to wait till a year later. It takes that long. But initially tell him he's in spinal shock right now. It's a process with spinal cord injury. We cannot determine how much sensation he will create. And then we're giving them the corticosteroids that's going to reduce the inflammation, et cetera, et cetera. Okay? We can't say, yes, he's going to be paralyzed for the rest of his life. No, he's not. He's going to get up and walk out in 30 minutes. Okay? So you got to be realistic. Okay?
Is spinal shock going to happen in all spinal injuries?
Pretty much so. It depends on the severity, but you got to anticipate that it's going to happen. And how would you monitor this patient? You're a brand new nurse working at J. They bring in a possible spinal cord injury. How do you monitor for spinal shock?
I will monitor BP.
His blood, start right there, his blood pressure. Because it's going to drop. And then you'll know what's going on with him. Okay? The doctor will order some medication using something called sedation to constrict the blood pressure. He may even get a bolus of fluid to try to get the pressure up until we can maintain that. Okay? But that's how you detect, because if you look at shock, one thing that all shocks have in common. It's not the origin of it, the etiology of it, but it's this right here. They are going to lose their blood pressure, okay? All right, so bradycardia, flaccid paralysis, bowel and bladder dysfunction may last 7 to 20 days. We don't know. That's what the book says, okay? And then after that, and he's going to be, treatment is what? Symptomatic. What does that mean, guys? Based on the symptoms. There's no magic bullet. Based on what he does is what we're going to treat, okay? So, here's the corticosteroids. And I need to slow down just a little bit, I think, okay? Did you get this on the test? I had one question on there with corticosteroids. It was a safety fall prevention. Yeah.
Oh man, did I keep that or did I change it? I think I did that, but I think I changed it. I think I changed it to blood
I
pressure.
think there was more than one answer. There was more than one question with corticosteroids. One of them was the safety, and one of them was the monitoring.
Yes.
Hypoglycemia was the answer to one of them. It was select all that applied.
Yeah.
You had a low potassium, but a high sodium. And that was it. I didn't put anything else on it, okay? The reason why you don't know your problem is because of this. They have injured themselves and may not ever heal. The skin is so fragile, okay? Now, corticosteroid is not anything new to you, okay? It's not new. Everybody gets corticosteroids for everything, okay? And we already know this. Don't think because I didn't test you today on that concept, it may not be next week or on the final. You either learn it and use it, or you can't memorize it, right? Because you already know that. Titrate before DCing to prevent adrenal insufficiency. Will we start oxygen on Winston? Yeah. I had the O2 in November, I was too forthcoming. Okay. Yes, because we want to oxygenate that cord. Give him as much as we can. If intubation, especially with a high cervical injury needed, neck cannot be flexed or extended. So how are you going to intubate him? What if you hyperextend the head?
It's gonna make it complete.
Do what?
Make it complete. Make it right.
And they make a complete transcending of the cord. So you can't hyperextend the neck. Remember you learned basic CPR? You do the jaw lift thing instead of hyperextending the neck. That's why you got rid of that hyperextending, because people are doing that on spinal cord injuries. Okay. So how would you intubate them?
Not be
You wouldn't do it. Somebody who's highly skilled has to intubate that patient. Okay? There's not going to be little lazy daisies or CRNA that just started. They're not going to be able to do it. They're going to get their most experienced person that's in that field to put that tube in. Okay? So sometimes we have to get each other, right? The most experienced person, because it's not about you. Who's it about? The patient. The patient. It's not about you looking good, trying to prove anything. You didn't go to school for it to be your crown. You went through this for it to be what? About saving somebody or helping somebody. If you got anything else in your head, you're going to have trouble in nursing. I'm just here to tell you that, okay? Yeah, they should pay you big paychecks, right? Anybody sit and go through what we done put y'all through? Should be making a lot of money. I have no problem with that. I have students say, I want to make some money. That's a good motivator. I wouldn't do it if I didn't make money either. Well, what comes first is the patient care. I don't want you to forget that. Spinal shock is a sympathetic reflex that's blocked. That's what's causing it. I'm trying to explain it to you over and over again So I don't want you to miss it on the final exam. Sudden depression or reflex activity in the spine below the injury, okay? Watch the respiration. They may not be able to cough, okay? Would you want them coughing anyway? Would you want Winston coughing?
No.
Why?
The increase, I think, is.
That's it. So you're working with two things now, okay? Bladder and bowel, they get a paralytic ileus. What's a paralytic ileus? What is a paralytic ileus? Shh. What's a paralytic ileus? I know you want to help her, and we're not doing a team thing right now, so I want to hear what she has to say.
A paralytic ileus is when basically you're not moving your you know, the little ribbon things, and it's not peristalsis.
Okay.
Thank you. It took me a minute, but I get there.
See, I know it's smart job when I can interpret what you're trying to say. I'm pretty smart. Okay. Most of your spinal cord injuries will lose peristalsis. So, Quinston, one of the things we will do for you during this acute stage is watch your abdomen. So we got a stethoscope on our necks, and we're doing bowel sounds, right? And we're checking for what? Paralytic ileus. I want you guys to remember this. Remember this forever. I'm talking about acute ill patients. And every one of your acute ill patients will develop a paralytic ileus. When I talk about a burn patient, can they develop a paralytic ileus? What about a patient that had a bad cardiac event? What else have you learned? Any acute bad situation, because the body compensates. And if it's trying to take care of the major organs, it'll go blocking blood supply to the GI tract. The GI tract is the last one that gets it. If the body needs something else, it's going to distribute blood or whatever to those parts, and the GI tract will go like it. We're designed that way. Okay? So, we're going to watch his bowel sounds, right? Respirations, watch his bowel sounds. We're going to watch his bladder, right? Because he won't be able to do what? He won't be able to empty it. So he's going to be stopped up and he can't urinate. We're going to put a catheter in. This is one time Coco would have put a catheter in, right? Okay. Okay. You put the catheter in for two reasons, and we don't advocate catheters. We're going to take them out ASAP. But we have to keep his bladder empty. That's one thing. What's the second reason why we're putting that catheter in?
Make sure his perfusion.
To his kidneys. The only way you know the kidney is getting blood supply if you produce urine. Okay? And how much urine do you produce?
30 cc's
an hour. Okay? At least. So that would be a reason for a catheter, because we don't just put them in. Okay? So let's say we got Quinston through that acute stage, that spinal shock stage. We got him through. Okay? And Coco, you taking care, you don't want me to call Coco. We done made up. You know we done made up, so I came back to see her. I feel so bad, I'm crying. I am just crying. Okay?
Hello,
But anyway, when I get in the room, Quinston says to me, oh, I got a bad headache. A bad headache. And I'm thinking he's stressed out because I'm in the room with him. So I called the nurse, and Coco answered, and I said, you know how that gets. Do something for him right now. Okay? So what would you do, Coco?
I'm going to assess Quincy first, and I'm going to see if it was sudden onset headache or has been going for a while.
It just came on.
It just came on. Then I'm going to
You're going to check it.
I'm going to check the headache, and then we're going to
It is 184 over 120. He has a headache, bad headache.
bad headache. I'm going to call somebody. Put my mother in the room
He's diaphoretic.
and tell them to call and bring me the blood sugar monitor. Blood sugar.
Stop talking.
He's not ready.
Okay, listen to me. Stop talking. You're doing a blood sugar. You're talking too fast. I can't keep up with you.
Blood sugars? I don't know what they say. Oh, 142. Then I'm gonna check the kink in his catheter.
Okay, that's where you're going. You gotta remember, after spinal shock resolved, then you go into this. Okay, AD. After you get over spinal shock, he can go into AD. Okay, is he over spinal shock? So he's gone into AD. They'll do it. I gotta say this and then I'll move on. I have a big picture in my living room of Denzel Washington. I'm gonna tell you where it came from. It came from the nursing students at Bishop State when I taught down there. They brought that movie marquee thing to me. And the first thing I asked was, and the director was in the room with me when they presented it to me. And they said, Dr. January, blah, 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 blah. And I said, and I looked over at the door, she said, she thinks Denzel Washington gonna walk through the door. Because I told them I'll dig out an impassion on Denzel without gloves. Okay? He's my favorite. But anyway, I used one of his movies that he depicted having a spinal cord injury in that condition. Bone collector. And that's what I used to teach that class. Some of them went and got the movie and looked at it, and they remembered DA. AD. I got it backwards. But they thought that they needed to reward me for that, so they went and got a movie marquee from somewhere. And I said, what movie theater is missing this? They were showing the movie then, but they ordered it online. I still have it. But when I saw that movie, and I was sitting there, and I told my husband, my ex-husband now, he's having autonomic hyperreflexia, and he doesn't know anything about medicine. He having what? I said, watch her. And the first thing she did, watch what she did to her. He started sweating profusely. He started having a seizure. His eyes turned red because his blood pressure went up so high. Anybody watch the movie? Okay. The first thing she did was say, she went to the catheter, and what did she say? I'm not going to say it.
She said, the damn catheter is king.
What did she say?
The damn catheter is
That's what she said. And she unclamped the catheter, and then she let his head up. Why did she let her? Whoever did that little part in that movie did good. She let his head up. The what? Yeah, why did she let his head up? She didn't know why, but I did. Okay, let me tell you why. Whenever a spinal cord injury is flat, the blood pressure, when you let the heads up, the blood pressure automatically drops. Got it? So what she was capitalizing on trying to get his blood pressure down is to go what? Let his head up to help the blood pressure drop right away. That's what she was doing. Okay? And then she checked for the catheter to see if it was clamped, because anything that's stimulating below that injury will cause this to happen. Okay? It can be covers on the bed. It can be wind, air blowing across the sheets. It can be, well, I want to say a fly landed on his leg. That's kind of far-fetched because it's not heavy enough. Any pressure. You walked in the room, and maybe when I came to Kristen's bed, I said, oh, baby, I'm so sorry. And I leaned on his legs. That's what I would have done.
Step away.
The what?
Ma'am, step away from the patient.
But when I stimulated his legs, guess what he went into?
AD. I read somewhere when they're asking about the sheets up under him and stuff. Can that do it? Wrinkles and sheets.
Wrinkles and sheets. Anything you do. But you got to recognize it because they can have seizures. And they can also stroke because the blood pressure goes up so high. Okay?
That's why he went
That's why he was having seizures in that movie. I told you they wrote that part there. Okay?
Dr. January,
Uh-huh.
I think I misunderstood something. You said that the autonomic or the AD
The sympathetic nervous system.
comes on after the spinal shock. Now, does that mean
The AD, yes.
is it after the spinal shock resolves, or is that just a sequence of events?
After the spinal shock resolved, he can't do it because the blood pressure is too low. He won't be able to do it until the spinal shock is resolved. Then he can, because the sympathetic nervous system's like that jolt to it, it's kind of recovering, so the blood pressure can go up.
Okay.
Won't be able to go up before then. Okay, all right, so, and then the other things are watching for patients that's immobilized, okay? This is on the quiz, so I gotta go through that. What kind of traction are we going to put on Kristen? What? What kind of traction? Go back to 201. I'll give you a minute to do that. What kind of traction are we going to use on Winston?
Halo.
A halo. Y'all remember that? Is it skeletal or skin?
Skeletal.
What?
Skeletal.
Skeletal. Okay? Once we get him, he's going to have surgery. And once he goes home, he's going to go home in a special contraction. Okay? The cervical fracture only reduce, align, stabilize. Wait, revisit care of the patient in the cervical traction, because you already learned it. And then we'll go to a halo traction. We can do surgery, okay? And this is a picture of a skeletal traction. If you don't remember, we do it for cervical spine fractures. Remember that? Okay, we got boreholes here, right? Into the skull, the bone, that's what makes it skeletal. Okay, the weights come off and hang off of the bed. Got it? Okay, so what, you know, I'm one of these wives now trying to be so sweet. Trying to be really, really sweet. This is just out of your med surg from 201. You don't even have to worry about it. But what if I came in and started acting ugly and they want to move Kristen to another room? You know we do that. We move them to another room, put them under anonymous so the person can't find them. Would we have to move him to another room? First of all, she would have never known where he was in that situation. I would have never, as his nurse, allowed for anybody to tell where he's at. Why?
She could finish the job.
He's a crime thing. She can come in and finish him off. So you got to think about that when you're out there nursing too, okay? But some of y'all, she can walk up to the desk, where is Kristen? He's right there. Yeah, because you were told, you know, everything. But anyway, be careful. Think about the situation. And delegate. Say, hey, don't tell anybody if you want to say this out. But anyway, why don't we have to move into another room? What would you do with the weights? What would you do with the weights? Can you put them on the bed temporarily? When can you move weights from a skeletal traction? Anytime it's a skeletal traction, when can you remove weights from it?
Never.
DC.
He's supposed to touch it.
Okay, here's another question. I'm going to give this one to,
What the doctor said?
help me out.
Hannah?
No, Hannah.
Hannah?
Hannah, you got this one. When we send Kristen home, he's going to be in this device. That's called a halo vest traction. I'm going pretty fast, okay? That page because it's not in your book. But it mentions it, doesn't have pictures of it. Don't call this out. Let Hannah answer this, because she's smart enough and she's intelligent and she remembered this from 201. Got it? What do you need to make sure of that this patient has with him at all times, period? Don't turn around this way. She's trying to tell her. You know the answer. I have confidence that you know the answer. I truly do.
I'm just thinking about skin integrity of under the vest.
Yeah, and we do teach that about that. But think emergency right now. What do you want to make sure? Let me tell you, if we had to do CPR, can we do it through that?
No.
This is, you see a lot of test questions dealing with that.
Phone a friend.
A what?
Phone a friend.
A what? Phone a friend? No. You know what? I'm going to say this and then I'll let you phone a friend. I watch faces, so you can't give me buffalo chips. There's some on each side of the room saying, they don't know either. They don't forget it. So go ahead and phone your friends since I said that. All y'all in the same boat, you know that, right? Remember some of this?
Do not answer this question.
See, I told you. What is it? A what?
Allen's Ranch.
Allen's Ranch. We're not gonna fix a Collier, but something. Oh, your test pressure. You can't get this off without it. You can't even. The what? Okay, guys, I gotta get the quiz in. So this is what I want you to do. This is a wrap up here. Spinal cord injuries are going to happen. And what age group is more at risk for them?
Young kids.
Young men.
Young men. Okay? And why?
Because they pray.
Okay, risk takers. Why?
Because they think they're invincible.
Why?
They're more dangerous. They're more willing to try.
Development.
They think about
Why?
Erickson said.
Thank you!
What? What was that?
Harrison's theory. It is true to life. They were supposed to be like that. Harrison did it himself. So he knows how human will behave. Okay? That's why you have to learn Harrison. Harrison shows up on growers too. Every now and then they throw some Harrison in there. Okay? So I want you to match the intervention with the problem with the spinal cord injury. Okay? And I'm going to alternate. So you have the first one. And this is what I want you to do. Maintain function at the highest level to prevent complications. That's what we want to do, right? Okay. So number one, why in the world would you put an NG tube down Princeton?
Onto an NG tube.
Uh-huh. Go ahead.
Because of the fact that they are going to have the
Paralytic ilias, the one with the waves that don't work.
That's it. The ribbons.
The ribbons that don't work. Paralytic ilias. How would you know if he was developing a paralytic ilias? So you're going to wait until the vowel sounds are not there?
Oh,
Now watch the bowel movement. Watch how much you go.
Okay, let me show you what I can do to you. What is the earliest sign of a small bowel obstruction? What? Distended abdomen. What else? Do you know that the vowel sounds are not absent early on? They're hyper early on. Why?
Trying to push it.
Trying to push it through. Go back to that now. So I went in the room and Clemson had hyperactive vowel sounds, but he's going to tell you a noise aided or something. There's a particular sound that you guys have not heard, and a doctor taught it to me years ago. And they're real high pitched, and he called them water bag sounds. And they're bloop, 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 just like that. Whenever you hear those vowel sounds, I had a student and said she wrote vowel sounds active. Now I went in and listened. You know why I went back and listened to the patient? Because of what was going on with him. I knew that what she heard with her knowledge base, that's all she could chart was what? Vowel sounds active. That's all she could chart. But when I listened and heard that sound, I knew then that that patient was going to get an NG tube. And right at the end of the shift, I told her, I said, don't feed him anything else. Okay, his bowels are obstructing. And the one, he started vomiting, and the last thing the doctor ordered right before we left was an NG tube. It's the sound that it makes. Absent vowel sounds is kind of like towards the end. Okay? Once you ever hear that, you'll remember it. She heard it, and I guarantee you, wherever she's nursing, she will remember it. I was taught that way. I had to hear it and then make the connection. Okay? But eventually, you will lose the vowel sounds with a paralytic ileus, and the NG tube is your resource. Now, seniors, why do we put down the NG tube? What's the purpose of it? Those who what?
To prevent.
I want to hear what she has to say.
To your being the content of the stuff.
Okay, for what purpose?
Backing up blocks and trying to look through so we can have some apparent.
And you don't want him vomiting and aspirating. We put the NG tube down. You know how we put it down a lot of times before we take them to surgery for a blockage? We always put an NG tube down for several days because if you rest the gut, and decompress the stomach, the bowel will open back up. It'll actually start functioning. That's why it's so imperative that you make that NG2 work correctly. I give you a question like, what do you do with the blue pigtail on the NG2? Where does it stay? And it's so important, guys. So important. See, I give you basic questions. If you don't remember stuff like that, it's more salient, then you miss your whole nursing career. Where does the blue pigtail stay at all times? Because the blue pigtail is how the tube works. If you do the wrong things with it, the tube doesn't work. Where does it say?
Plug in, outlet plug.
Okay, let me move on. Pneumatic hoses. Why do we put those on? TB hoses. The what? To prevent DVTs. Excellent. Adequate hydration. Why do we want to make sure the question is adequately hydrated?
Maintains good stuff.
The what?
It helps.
Excellent. No, I'm not cutting you off. I did that to some 8th graders. They love it. If he gets dehydrated, he can develop a clot. Anybody at risk for a clot must stay hydrated well. If they become dehydrated, the blood is more viscous and they will develop a clot. That's why you see so many people developing deep vein thrombosis in the summertime. Okay? Yes?
Can that also affect them getting like rhabdomyolysis with them?
The muscle?
Yeah, with the muscles not being used and stuff, would it cause it to occur quicker?
It could. It could. It could. Okay. Gallbells heparin. Clots. Calf measurements. DVTs. Watch for low-grade fever. DVTs. Yeah, DVTs. That's how I know they got one. They'll start with a low-grade fever, and then you got a leg that's unequal. You put it together with the fact that he's immobilized. See, it's a whole lot of things.
Can
Okay?
it also be affected by that autonomic hyperreflexia?
What's that?
The temperature. I
No,
watched a YouTube video that
not really. If they got like a low-grade temperature, 100.4 or greater, a clinical temperature is 100.4, then something else is going on, and a DVT early on will cause a little bit of temperature. As
I
well.
watched a video that said if they had, sometimes that if something was going on in the lower part of that, they would start,
Having a little
they
fever.
would have a little bit of a fever, and once they resolve that, it would.
First thing I would think about is a deep vein thrombosis, is what I would think about. Then maybe a urinary tract infection too, okay? Because they can't empty the bladder. Or external pressure on the lower extremities. Why? Okay? Monitor motor and sensory dysfunction and report new development immediately. So you're going to do your 2-point discrimination, sharp, dull, lowest level. You're going to continue that on Princeton the whole time he's in the hospital, right? And if he develops where he's losing sensation somewhere, you're going to do what? You're going to report it. It doesn't stop, okay? Monitor respiratory activity. What are these signs of? Shortness of breath, pruritic chest pains, and then your O2 sat starts dropping. What is it? Pulmonary emboli, and they will develop it, yes.
With the TEDos, you wouldn't put STDs on.
You may not.
Because the constant pressure change.
You may not. You may not, but you can use, it depends on your patient. You know that TDs is an STDs. You may see them ordered on the patient. There's no magic bullet. We will put them on, and if they start having problems, guess what we're going to do? That's it. That's how we operate in nursing. It's no quick fix. The doctor may order them. I'm not going to tell the doctor, no, I'm not going to put this on because he can go into AD. hour trial. If he goes into AD, I know next time not to put him on. And that's what nurses do, okay? We know exactly when to release stuff and tell the doctor we can't do this because it's sitting in. We don't know what's going to stimulate it, okay? These are things that may, okay? Monitor the areas for perspiration and areas that do not perspire. The lever injury. Quinston can get wet from head to toe. Remember he started getting diaphoretic? Below that lever will be dry. Will not perspire. Yes. Yes, that's it. That's how we know the area may be not getting the nerve innervation. We want to try. All right. All right. Log roll. Keep head in neutral position during turning. Okay. And help patient with diaphragmatic breathing. How do you do diaphragmatic breathing? That's 102 now. That's way back in 102.
In the first lip.
That's for COPD.
Do this. I know, it must be measured.
You know what, at West Florida, no, you're talking about diaphragmatic excursion. You gotta go back to that next week, too. But diaphragmatic breathing or coughing. I had a patient who was at West Florida with spinal cord injury, and he needed someone to help him cough. And I told the student to go in and do diaphragmatic coughing, and she couldn't do it. Push on the diaphragm. Usually a nurse get over it and push. His wife had to come in and do it for him. She said, I don't remember what it was.
So while they're breathing, you just, like each
You know,
time
they
they breathe?
And they'll show you how to do it. They'll show you because they get taught to do it. And that's why you learn diaphragmatic breathing and coughing, so you can teach a patient how to do it, especially spinal cord injury. You didn't make the connection then because it was so early. Suction as needed, but you want to be cautious, right? How long do you leave it down?
10, 15.
But you do suction, right? I think it was a test question on that today.
You could leave it for 30 minutes, I think was one of your answers.
I hope you didn't leave it for 30
No, I'm
minutes.
saying.
The other one was only suction or not any ETT.
Yeah.
And why are you chicken?
You have to do that one.
Yeah, why are you chicken? That question, I didn't write that. That question was seeing if the student was chicken. You know how we don't want to touch a tube, but it's full of snot and gunk? And it's the tube he's breathing out, I will go ahead and suction him out and come out because that's all we have to do. You can't chicken. Get down in that tube. You're required to do it. That's what it gets there. Chest x-ray and no smoking. And I think that's it. I think that's it. That was the end of it. Now, I do want to ask you this. Guys, listen to me before you take your test. I know you're tired. I know you're tired. Is it possible, and Quinston, I'm not going to even use you in this scenario because I won't be too embarrassed.
Why? What is it?
You'll see it when I get it. You have a young man who's had a spinal cord injury and he's married. Okay? He has lost sensation from the middle down. He's 25 years of age.
Oh, man.
Now, there are some psychosocial things you need to be concerned about. Okay? He is very concerned about sexual activity. What would you tell him? Sorry, bud.
There's a lot of light in it.
Do I?
Just happened. Couldn't like this well.
No, this is long term. We're taking it from acute into chronic long term because he's going to be a spinal cord injury until the day he dies. And we won't know how much he's going to gain back for a year. It takes a good year. What would you tell him?
So this is after the years passed.
He probably going to ask you that before you leave the hospital because his wife going to push it.
Well, I mean, you can be honest with him. I mean, if it's been past a year, you don't want to continue to give him false hope. I mean, you would tell him in the most general way possible, if at this point in time
that sensation has returned, it's not going to? Or is that just being a?
And then would you refer them to counseling, both of them?
I would refer them, okay? Because there are ways, and it's bad English, that they can have a satisfactory, I can't even say the word, satisfactory, because I guess I don't worry about that anymore, intimacy,
So,
okay?
the man too?
Ultimate therapy.
He won't, not saying he won't feel
No,
that.
no,
Okay.
he will not, but there's, remember until one you learn penile implants.
That was close like
But you gotta consider the psychosocial, okay? Now, let me tell you guys, you've never taken care of a patient with a spinal cord injury in the early stage. A lot of divorces happen with spinal cord injury patients. Okay, they're young men, but the acting out is tremendous. And even as nurses, it's hard sometimes to tolerate them. But you've got to understand what they're going through, okay? Even their masculinity has been taken away from them, not only just their mobility, okay? Now, I will tell you, if they got a head injury, and I've seen this so many times, and spinal cord injury, head injury, they have to evolve up. You understand what I'm saying? They evolve up from a child up. So they have infantile behaviors for a while. And families don't get it. They don't understand that it's very taxing, okay? So there's times where you do have to refer them. And it can break a family apart. A spinal cord injury and a head injury can be devastating psychosocially to a family if they don't understand that. All right, so this is what I want you to do. I want you to count off in 6. Ready? 1, 2, 3, 4, 5. Okay, let me stop right there. When you say you're going to get up and come up here, I know what y'all are doing, I'm messing up. You're trying to get in the group with whoever you want to be in. It ain't going to happen today.
You want one?
I've been teaching for a while.
We can't trick you anymore, huh?
No, you can't. You never could. You couldn't trick any of us. We just let you get away with stuff. Yeah. 1, 2, 3, 4, 5. I said 6.
Stop this at
Okay, I want 6. 6, go to the back. You move over here with it, because I got to figure it out. 1. Where's 1? Give it her. 2, 3. Okay. 4. Look and look at this, and what I'm going to tell you is the same, okay? Now, I will tell you, in order to do well on the Burns test, we haven't even talked about respiratory. If you do not have a working knowledge of fluid and electrolytes, ABG's interpretation, function of the skin, or pain management, you need to go back and review those, right? Okay. You know, I always do a snippet of knowledge. And you know why I do that? It's not to make you feel bad if you don't know. I'm trying to encourage you to go back and do what? Review. Okay? The bottom line is you have to know it. Okay? So, if a patient is dehydrated, do you expect for the patient to have metabolic acidosis or alkalosis? Do you expect for the H&H to be elevated or low? Okay, so y'all do remember some of it, okay? If the sodium level is low, what do you expect for the potassium level to be? High. Okay. Now, there was one question on the test today that dealt with fluid and electrolyte. Patient had a sodium level what? 117. Very significant. If you don't have foundation, you can't move forward. Okay? So what you need to do is go back and review. What is the best way to treat pain? What's the concept? The concept is the same no matter who you take care of. What's the best way to treat pain?
Treat it before it's bad.
Treat it before it gets bad. How do you do that? So what? Around the clock with what? With a PRN for what? For breakthrough pain. Remember learning that in 104? Okay, that's what the book talks about when you treat burn patients. Or a post-op patient, or any patient. Those concepts does not change, guys, okay? And that's what you fail to realize, is that you're supposed to be using what you already have in this class. And I know you got it. If not, then you got to review. And I can't help that you didn't get it in the past, okay? You got it? I didn't even know she was late. Some things I will pay attention to.
Being not in 30 seconds, you just walked off.
Okay, guys, I'll let you watch this. I hate that it's small, but hey, it is what it is. And I will explain all of this, okay?
Often with tragic and life-altering results. Burn injuries happen to people who are old and young, strong and frail. They happen on the job and at home, accidentally and deliberately. However they occur, burns produce trauma, both physical and emotional. And it is that trauma which is the primary immediate focus of burn care. Burns have been a multidisciplinary medical specialty only a short time. The first burn unit was established in Russia in 1938. Today, there are more than 200 burn units in North America alone. In these highly focused environments, teams of specialized professionals work together to meet the complex, multidisciplinary needs of burn patients.
In the 1950s, a patient who had 30% of his body burned only had a 50% chance of survival. In the 1970s, burn centers were developed, and in these centers, specialties in medical care gathered together with specialized nurses and with the equipment that was needed to meet this challenge of saving lives. As a result, the patient now with a 70% burn has a 50% chance of survival.
A burn center consists of a team of specialized professionals who administer complete care to the patient and family. The burn team includes surgeons, physician's assistants who work directly with the physicians, specialized burn nurses, physical and occupational therapists, dietitians, social workers, and members of many other medical disciplines. The burn patient's needs are extensive, multidimensional, and constantly shifting. In emergency burn care, everything depends on the patient's status. You have to continually look at the total clinical picture and address the most pressing issues first. Burn care has to be individualized to the patient's needs, but always, always first treat the ABCs. I've seen patients come into the emergency room and everyone is so busy looking down at this terrible burn that they don't notice the patient isn't breathing. Remember that what comes first always comes first. You have to meet your patients where they are. Burn trauma has a severe pathophysiological impact on the body systems. This kind of trauma affects every one of the body systems: the heart, the kidneys, the liver, the stomach, everything. With the loss of the skin, the body loses its mechanism for protection against infection and outside forces. It also loses its mechanism for temperature control. Burn patients become hypothermic. They need to be kept warm.
Also, with the loss of the skin, the human body begins to shift fluids from the intravascular to the interstitial spaces. Therefore, even though burn patients may be grossly edematous, may have blisters or weeping wounds, they can be starved for fluids at a cellular level. This is why burn patients require acute fluid resuscitation.
Emergency burn treatment is very similar for adults and children. The major differences come in judging the percentage of the body burned and in the amount of fluids needed, both resuscitative and maintenance. Generally, children 14 or older are considered adults. However, when determining treatment for older children who are developing at different rates, you should base your decision on observation, not on strict chronological age. Whatever the source of the burn, thermal, electrical, or chemical, your first concern is to stop the burning. Then cool the burn with tap water. Remove any burned clothing or clothing covering the burn. Remove all jewelry. Any material firmly stuck to the burn wound is best left in place until the patient reaches the burn center. After you stop the burning, the first and most important thing to check for in a burn patient is breathing. If the patient is not breathing, use whatever means are necessary to maintain a patent airway. If you even suspect respiratory involvement, have the physician intubate the patient immediately. The rule is, if you think you might need to intubate, do it. Suspect respiratory involvement if the following indicators are present. Was the patient burned in an enclosed space, trapped in a house fire or a car? Does the patient have red or charred oral or nasal mucosa? Does the patient have singed hair, eyebrows, or nasal hair? Does the patient have a hoarse or raspy cough? Does the patient have soot on their teeth, tongue, or in their nares? Or does the patient have circumferential burns of the neck? Remember, early intubation in a burned patient can often mean the difference between life and death. After you have established an airway and stabilized ventilation, the second step is to assess vital signs. Check the patient's pulse, centrally and in all peripheral sites. Take their blood pressure, placing a cuff directly on the burn if necessary. Hook the patient up to a monitor and determine the cardiac rhythm. At all times, protect the C-spine. Ensure proper C-spine alignment until cleared. Burn victims who have been in explosions or who have been electrocuted are particularly liable to have spinal injuries. If possible, have the lab technicians draw blood for chemistry and lab work. Take chest x-rays and any other x-rays which are indicated. And get the patient started on fluids.
Because cell membrane permeability is affected and the fluids shift in reaction to a burn injury, there is a constant threat of hypovolemic shock. Left untreated, hypovolemic shock can be the cause of death early in the course of a burn. Therefore, you need to begin a burn patient on resuscitative fluids immediately.
Start a large bore IV catheter or two if possible for all major burns. Insert the IV through unburned skin. If necessary, however, start the IV through burned skin and secure it in place with sutures. Begin administering Ringer's lactate IV. Later, when you've had a chance to calculate the burn size, you can figure out the IV fluid rate. At this stage, however, you will simply want to get the IVs in and running. You only need to consider fluid overload in very small babies and very old people. Treat the patient for shock. Keep them warm and reassured. Update them on their progress. Describe what you are doing and why in simple terms. Finally, treat any concomitant injuries. There are several specific injuries to check for, including head injuries, fractures, spinal injuries, soft tissue damage, and the presence of any foreign bodies, especially after an explosion. Examine the patient for both internal and external bleeding. Since burns do not bleed, if there is a lot of blood, look again for other injuries. The burn injury itself will not cause a loss of consciousness. On arrival, if a burn patient is not awake, alert and oriented, look for causes. Is the patient hypoxic? Is there a head injury? Even though severely injured burn patients may present alert and oriented, their status is likely to deteriorate. Their mental status will change. As hypovolemia and electrolyte imbalance progress, the patient will become confused and disoriented or lethargic. In estimating the severity of the burn injury, there are several points to consider. The percentage and area of the patient's body which has been burned, the depth of the burn, the cause of the burn, and the patient's age and medical history. As you examine the patient, ask yourself these questions. Burn size. Is the area of the burn injury over 10% of the patient's body? Burn location. Does the burn involve the face, hands, feet, perineum, joints, or is it circumferential? The cause of the burn, thermal, electrical, or chemical burn. Age, is the patient under 10 or over 50? Medical history, does the patient have a history of chronic or severe illness? Part of any assessment includes obtaining a thorough history, either from the patient or from family and friends. Find out the patient's age, medical and surgical problems, how the burn occurred, and as many details about the incident as possible. Also, get any post-burn history, such as when IV fluid intake began and what other treatments or medications the patient has received. It is important to discover whether the burn was thermal, electrical, or chemical, since there are variations in treatment for each type of burn.
Thermal burns, which are caused by flames, scalding, steam, sun, or the contact with very hot objects, are the most common types of burn injury. In treating thermal burns, first treat the patient for trauma, stabilizing their respiratory and circulatory system. Then, remove all burn material and clothing from the patient in order to estimate the severity of the burn and begin treatment. Be certain to monitor the patient's pulse in his circumferentially burned extremity.
When treating patients with electrical burns, again, the first step is to treat the patient for trauma, stabilizing the respiratory and circulatory systems. However, there are several concerns specific to electrical burns. Electrical burn injuries are often called tip of the iceberg injuries. The entrance and exit wounds are not indicative of the entire damage. Electricity follows the path of least resistance and will travel on skin, vessels, bones, nerves, any conduit. Since electrical burns can cause electrical disturbances in the heart, patients with electrical burns have a high incidence of cardiac arrest and arrhythmias. These patients should be closely watched and receive cardiac monitoring for at least 24 hours. Patients with electrical burns have increased fluid requirements. You may judge this based on color and amount of urinary output. Maintain a strict fluid protocol and calculate the necessary fluid volume at a higher rate than for a thermal or chemical burn patient.
Chemical burns are the third major type of burn. Again, there are several immediate steps specific to chemical burns. Check for steam involvement. Because steam penetrates deep into the lungs, chemical steam injuries require immediate ventilatory support. If there is loose chemical powder, brush it off, being careful not to contaminate yourself. Then remove all clothing, including shoes and jewelry. Chemicals could be trapped inside them. Do not try to neutralize a chemical burn, just flush with water. Regardless of what has happened at the scene, in all chemical burns except phosphorus burns, flush the burn repeatedly with low pressure running water for at least an hour. Do not quit flushing until you are positive that the chemical has been removed as completely as possible. Chemicals continue to burn. Therefore, if you do not remove all of the chemicals, a first-degree burn can become a second-degree burn, and a second-degree burn can become a third-degree burn. Finally, analyze the chemical to determine any further specific steps. Phosphorus, hydrochloric acid, and other highly caustic solutions require special care.
Now that you know the patient's medical history and the source of the burn injury, use the rule of nines to calculate the total body surface area which has been burned. The rule of nines divides the entire human body into percentages. The patient's palm size equals 1%. You can use this as a guide to estimate any spotty areas. The face and neck is 4.5%. The back of the head is 4.5%. The anterior trunk is 18%, divided into equal portions for the upper and lower trunk. The posterior trunk is 18%, divided into equal portions for the upper and lower trunk. Each arm is 9%. Each leg is 18%, divided into equal portions, anterior and posterior. The perineum is 1%. For children younger than 14, the formula is a little different. In fact, the proportions shift within 3 pediatric age groups, 1 to 4, 5 to 9, and 10 to 14. In all 3 age groups, the percentage allocated to the trunk and arms remains constant, but the proportions of the head and legs change with age. Finally, estimate the depth of the burn injury. What percentage of the injuries are first, second, and third degree? First degree burns are superficial burns, like a bad sunburn. They are considered partial thickness burns because they only damage the uppermost layer of the skin, the epidermis. First degree burns are reddened, will blanch, are painful and tender to the touch, and will heal themselves if kept clean. Second degree burns are deeper, partial thickness burns, extending into the upper layers of the dermis. They may have blisters or may leak fluids. They are painful and tender to the touch. Second degree burns will not usually require autografting, but will require some form of covering to promote wound healing and skin regrowth. Third degree burns are full thickness burns, extending through the deep layers of the dermis where the hair follicles and sweat glands are located. The skin is destroyed completely. The wound may be hard, leathery, white, black, or red, and will not blanch. The patient may not be able to feel your touch. Third degree burns require grafting with the patient's own skin. If the burn has gone beyond the skin into muscle, bone, or organ tissue, or if the patient's extremities have been charred, it is considered a fourth degree burn. Primarily, you will be dealing with second and third degree burns. After assessing the extent and severity of the burn injury, begin to treat the burn itself. You can calculate the amount of Ringer's lactate the patient needs based on the extent of the burn and the patient's body size. Adults should receive a total of 2 to 4 milliliters of Ringer's lactate times their body weight in kilos times the percentage of the burn area.
You don't have to write that.
Children should receive a total of 3 to 4 milliliters of Ringer's lactate times their body weight in kilos times the percent of the burn area. Infants and small children need maintenance fluids in addition to resuscitation fluids.
Both adults and children should receive half of their total fluids in the first 8 hours post-burn and the other half in the following 16 hours. This is particularly important if significant time has elapsed between the burn incident and the onset of fluid intake. Play catch-up if necessary to provide adequate fluids.
Once the fluid intake is established, insert a Foley catheter with a urometer to monitor the patient's output for both quantity and color. Urine output is an indication of the progression and treatment of hypovolemic shock. The appropriate range of output varies according to age and condition. In the case of high voltage electrical injury, the output should be 75 to 100 cc's an hour to prevent renal failure due to deposits of myoglobin from damaged muscle in the kidney tubules. For other adults or young adolescents, it should be 30 to 50 cc's an hour. And for children under 30 kilograms, it should be 1 cc per kilogram per hour.
If the output seems to be adequate, we monitor it every hour. If it is less than adequate, we monitor it every 15 minutes. If urine is absent, we check the Foley replacement and suspect inadequate IV fluids. If the patient's urine is dark, they may have myoglobin or hemoglobin blocking their kidneys. If the urine is black, brown, or dark red, we administer 25 grams of mannitol, followed by 2 ampules of sodium bicarb to flush the renal tubules and to prevent renal failure. The children's dosage of mannitol is much lower. 200 milligrams per kilogram is given over 3 to 5 minutes, followed by 1 milliequivalent of sodium bicarbonate per kilogram. Mannitol, like all medications, should be given through the IV. If the urinary output is not adequate, increase the IV fluid rate.
If the patient has burns covering more than 20% of the body, or has facial and/or inhalation involvement, or is going to be transported by air, insert a nasogastric tube to decompress the stomach and to suction the contents. If the patient is not intubated and the blood pressure is acceptable, position the head of the bed at a 30-degree angle. Elevate burned hands and arms about the heart level. This may require 3 pillows each. Remember to keep the patient warm. The combination of loss of skin and shifting fluids undermine the body's natural temperature control mechanism. Trauma further complicates the situation. By now, you should be receiving the results of earlier lab tests. The main tests, whose results will indicate how you proceed, are an SMA-18, which tests a panel of 18 electrolytes, a complete blood count, an arterial blood gas, which tests how well oxygenated the patient is, a urinalysis, and a chest x-ray. If the patient was burned in an enclosed area, you should also have a carboxyhemoglobin. The results of these tests may lead you to adjust fluid and oxygen intake and may indicate treatment of other concomitant injuries. Finally, medicate the patient for tetanus and pain relief. If the patient is unsure of their last immunization, give a tetanus toxoid antitoxin. Administer tetanus IM. This is the only medication to be given IM. If the patient is in pain, medicate the patient for pain.
Adequate relief of pain is not just important for humanitarian reasons. Patients who have adequate pain relief burn fewer calories and therefore heal faster and have better graft take. Adequate pain relief can also significantly reduce psychiatric morbidity among patients and among burn team members.
Pain medication is administered in small, frequent doses as needed. Morphine sulfate IV is the drug of choice for pain relief. If the patient is allergic to morphine, use Demerol or another IV narcotic agent. Remember to only administer medication through the IV route. Circulatory changes due to the burn injury make absorption of IM medications erratic and unpredictable. Often, burn patients sustain severe wounds. These are both from the burn injury itself and from concomitant wound injuries. If time does not permit proper wound care, nurses can rinse wounds with a saline solution and wrap the patient in sterile material. Once the burn patient has been stabilized by addressing both burn trauma and concomitant injuries, continue to monitor the patient carefully.
Because burn injuries are traumatic to all the body systems, you must continue to monitor burn patients closely. Maintain continuous multi-system assessment, reviewing and re-reviewing neurological status, respiratory status, cardiac and circulatory status, and renal function. Reassess your patient constantly and be attuned to trends in vital signs. When monitoring vital signs, check peripheral pulses in all extremities. Use a Doppler if necessary to monitor pulses in burned extremities. If the arms, legs, or torso are burned circumferentially, be alert to the need for an escharotomy. If you have a circumferential burn, the resulting trauma and edema may cause swelling to the point that the blood vessels and nerves are compressed, and blood flow to that extremity may be diminished or absent. If the patient's trunk is burned circumferentially, the trunk may tighten to the point that the lungs can't expand adequately, even if the patient is on a ventilator. In all cases of circumferential burns, consult a burn center for assistance in performing an escharotomy.
The care and rehabilitation of burn patients presents complex issues. Often these are best handled by the burn trauma specialists at dedicated institutions. In making your assessment, be sure to consider 3 areas: the percentage and placement of second and third degree burns, the presence of any electrical or certain chemical burns, and the threat of medical complications. According to ABA guidelines, these are the specific criteria under which you should transfer the patient to a burn center. Second and third degree burns covering more than 10% of the total body area in patients younger than 10 or older than 50. Second and third degree burns covering more than 20% of the total body area in patients between the ages of 10 and 50. Third degree burns covering more than 5% of the total body area in patients of any age. All second and third degree burns with threat of functional or cosmetic impairment to face, hands, feet, genitalia, perineum, and major joints. All circumferential burns of the extremities and or the chest. All electrical burns, including lightning injury. Burns involving inhalation injury. Burns involving concomitant trauma in which the burn injury poses the greatest risk of morbidity or mortality. Burns in patients with pre-existing medical conditions that may complicate management and or prolong recovery. Emergency care of burn patients is complex, critical, and continually challenging. Every system is affected. Every system is traumatized. You must constantly assess and reassess the patient's condition, choosing among imperative physiological interventions. Your care of the burn patient in those first critical hours can determine their chances of survival and the ultimate quality of their life.
That is my whole text. You should watch it again afterwards when it makes more sense. Okay? Can you put the lights on for me back there, please? You have your PowerPoint. But I always start out with this little picture because sometimes it's hard for you to get it. That's hard for me. It's also on page 516, okay? And I've been giving it forever. I don't know where I stole it from, but I've been using it forever. Yeah, it's in this book. It hadn't always been in the book. It wasn't in the other one. And I'm glad to see it in here because if you understand that picture, you got most of what I'm looking for on my burn test was on that film and it's in your book. So,
516, yeah.
Okay.
Okay, I'm going to start out slow. And all I want you to do is tell me the functions of the skin.
Protection.
Huh?
Protection.
Okay. All right. Let me write it down, and I'm going to show you how you need to use that information, not just call it out. What was it?
Protection.
Temperature regulation. I'll explain what that is in a minute. Temperature regulation, right? So you know that about the skin. So when I give you a test question about, do you leave a burn patient uncovered? What is the answer?
No.
No. Some people say, yeah, to cool the burn, they can't regulate their temperature because they're missing skin. Okay, another function.
Protection.
Protection. From what? Infection. So are they at risk for infection?
Yes.
Yes, they are. What type of infection?
Bacterial, viral.
The what? Nosocomium. Okay. Staph infection. Why?
It's on, is it already on the skin?
Have to know anatomy. That's why we give a lot of vancomycin to burn patients. Okay? What's another function of the skin?
Pain, texture, and feel.
The what? The what? Okay, so it's sterilized. And you know that, right? Okay, so does a burn hurt? Yes. Tremendously. So you'd be ready to do what? Pain management. And what type of burns?
Oh. No, second and third.
Now let me tell you something about that, because don't get it wrong. Third degree burns do not hurt. Full thickness burns do not hurt. Why? They're burned all the way through. The nerves, some burns I've seen that burn all the way down to the bone. But there's, guys, use your critical thinking. There's never a complete, full third degree burn that's not mixed. Now I've seen a leg that was burned down to the bone. It was just charred. But he still had some mix above that, so he was still in pain. They actually feel numb because the nerves are burned all the way through. Okay? So you still have to do pain management. I smiled when the film was going because I had a test question. One of the students debated. It doesn't matter if you debate, if you're okay with it, I'm okay. Okay? My job is to make sure, what's my number one job for being here? Safety. To make sure that you're safe when you get out there. Patients don't deserve any less, okay? But she said to me, Dr. January, you said you got to give all of the medicines IV because of they're so swollen. She said, but what about that, the tetanus? Mm-hmm. I said, have you ever in your life known to give tetanus IV? That's not a debate. You got to give it IV. So don't debate with me. Just do your job, okay? Go give it IV. And it's in the book. I laughed when they were talking about the tetanus shot because I remember what she said. It doesn't matter. She learned the hard way that my cage can't be regular. Okay, maintain normal body temperature. Other functions of the skin.
Sweat.
Sweat. Protect the body from excessive water loss. So a burn patient who's lost his skin, can they lose fluids?
Yes.
Yes.
Very rapid.
So why do you cover a burn? Give me the reasons why.
Protection.
Protection from pain.
Temperature.
Temperature regulation.
And fluid loss.
And infection. You just got one of my multiples. It's just that easy, guys, if you understand and not try to make it lofty, okay? I'm trying to help you get out of this class. Please do. I'm not going to cheat. Knowledge, you can't cheat, no. Okay, it synthesizes vitamin D. You know that, right? I don't do anything with that. That's a nursing home thing y'all have to know. How often you rotate them in the sun? You don't rotate the old people in the nursing home in the sun? They got a protocol that you rotate them in the sun with no sunscreen on. Did y'all not know that? No, ma'am. Y'all didn't learn that during long-term care.
That's what I be trying to tell you.
Because I don't care. You know what the lawyer says? If you didn't know it, you should have known it. You went through the class, you should have known it. Isn't that so? I don't do vitamin D. Okay? It has nothing really to do with burns, but you can understand that a patient who loses skin may have some problems with vitamin D synthesis because the skin does help with that. This is the normal skin, okay? And I'm almost done with the structure, but if you understand the structure of the skin and the function of the skin, all you have to do is apply that knowledge, yeah? You don't have to learn every nuances of things, okay? So, a full thickness burn is burned all the way down to the fat tissue. Got it? The film made a good point. Will that burn bleed?
No.
Why?
Because the heat basically cauterizing vessels.
That's it. That's it. If it's a full thickness burn all the way down to the fat tissue, will they require a skin graft? Yes. Yes. Okay? If it's a full thickness burn all the way down through the fat tissue, will that place have hair growth on it?
No.
What about sweat?
No.
What about oils?
No.
That's why we teach them when they leave to use aloe vera lotion. Okay? It will stay dry forever. Okay? So, all right, and then you have male and hair, sebaceous glands, and sweat glands. There's another hair follicle, sebaceous gland, etc. So it's very, now, this information is on in the previous chapter, if you want to go back and look at it. These are normal bacterials on your skin. See that? So that's how we know what to use, because they live there all the time. They're indigenous to your skin. Okay, physiological changes that impact the skin, from dermatological disorders and burns. Body image, you think the burn patient is going to deal with that? Yes. Social isolation and fear of rejection, embarrassment? Yes. Restriction in physical activity? Yes. Okay. Disturbance, loss of employment, cost of medical costs is extreme. Now, before I go into the medications you have to learn and you need to learn before next week, I want to say one thing that Cammie brought out earlier. You said Santa Rosa County. And I used to have a picture on there with a house trailer that showed a meth lab. I took it off. And the reason why I did that is because your meth labs are the #1 reasons for burns now. These labs that they're producing drugs in, okay? That is so involved, guys, that you're going to run into it. And I'm going to talk to it for just a little bit before I let you tell them what you found out. I learned a long time ago that when people come in with burns and chemicals, and they have a white residue on them, they said it on the film because they said what it was made of, you better not put water on it. If you do, you better flush it tremendously. You put a little bit of water on it, what's going to happen?
Spray it.
They are ignite. Yes. That's why the film say brush off anything white or powdery. Remember the film said that?
Yeah.
And they call it phosphorus? If you put just a little bit of water, you see nurses in the ER had to go through a class on that when they first started making meth. Because patients were catching on fire because they did what? Put that little bit of, whoop, because that's what happened. It was a chemical reaction, okay? So you guys are dealing with some things out there, especially with this drug. But now you can tell them what they Santa Rosa, and maybe y'all know it. I was interested to learn that.
Well, I did my EO observation at J Hospital. We were talking about the reportable incidences like the gunshot, stabbing, that kind of thing. Santa Rosa County now requires the emergency rooms to report any burns that are greater than 10% of the body, or they have to be centrally located on the arms and the chest. The police have to be notified so they can go out and check the area where the burn occurred, so they'll know whether it's a meth burn or not.
Wow. Isn't that interesting? Is it for children or just for grown-ups?
It is anybody.
Anybody. So you get, I mean, when you see things starting to change because of social events, it's going to become universal. It's just beginning. Santa Rosa is probably just jumping on because they got a high incident of drugs. Now you think about it. These people are producing drugs. It's the highest incidence of burns now. That's who you're going to get that's burned. These people who are making these illegal drugs and coming in burned. Think about the cost. Half of them don't have insurance, or none of them have insurance. And this is a very major thing for our health. It's putting a burden on our healthcare system. Really, truly it is. Okay? There's nothing we can do about it as nurses but take care of the best of our abilities. Right? That's all we can do. Okay? Now, I always teach the medications first. Okay? And I'm going to give those to you, and then I'm going to go back to this, because then we're going to get into how to treat the burns. But I always like to do the medication, because that's the hardest thing for y'all to get, right? Okay. The medications are on page 533 and 534. You don't have to learn them all, but try to learn them so you know them. And you're supposed to study these when? Now. Thank you. Not the night before the test. I know you're going to put that verse first. Okay. On page 533, it talks about, it just highlights all of them in the chart, but it has the tetanus toxoid there, the first one. Why, when you get a burn patient come in the hospital, you need to find out when they have the last tetanus shot? Why do you think you need to do that? For what? Infection? Yes. And plus the skin is missing. Tetanus is in the environment. So you want to make sure when they have the last one to offset tetanus. Okay? I'm on page 533. Now turn to page 534 and I'm going to give you these medications to start to learn. Okay? The first one is Cyberdine, the first medication. On page 533. You see Cyberdine? Okay. Binds to bacterial cell wall. I don't care about that. Okay. Absorbed into the eschar tissue less than other drugs. Do you know what that means? If you were a nurse and I gave you a stem that the patient has thick eschar tissue on his burns, is that the medication of choice? No. Why?
Because
it will not penetrate it. You know all of my questions are application. You know that, right? Okay. It will not penetrate it. So while even if you were in a hospital setting and you were using Cyberdine cream on a wound that you know had thick eschar tissue, you're just going to keep using it, or would you say something to the doctor? You will say something, okay? Because the patient is not going to get well, and that's what the bottom line is. It's about the patient. Sulfamylon, the next one. Methadone acetate. And I'll tell you what I need for you to know about that, okay? It does penetrate eschar tissue. It's a good medication to use. See on disadvantage. See on the disadvantage is the third medication down. See on the disadvantage. It creates metabolic acidosis. Now the reason why I'm giving you stuff is for safety. I'm picking out stuff to keep the patient safe. Like the eschar tissue, they're never going to get well. The Cyberdine is not going to hurt them, it's just not going to help them, right? With this, the sulfamylon is a very good cream to use on burns, but the safety issue is it will send the patient into what? Metabolic acidosis. You will see that in a generalized question dealing with sulfamylon because it's about safety. You need to know whatever it is to keep the patient safe. So if I give you a question that the patient is having Kussmaul respiration and you just put some sulfamylon cream on it, what do you do?
Get it off.
Do what? Get it off. Okay. I give you another test question that says you just put some sulfamylon cream on the patient and he's complaining of severe pain. What would you do?
It's normal for 30 to 40 minutes.
Do what?
It's normal for 30 to 40 minutes.
It's expected for 30 to 40 minutes. So what do you do as a nurse?
Pre-medicate.
Pre-medicate them. I got one of the students in the lab over that. She was getting ready to take out a bunch of staples. And I said, what do you do first? She was getting ready to take the staples out because that's a skill thing, right? She said, and Bruce said, you need to pre-medicate her. Then she had to push the morphine. She pushed the morphine. Guess what she did when she pushed it? Didn't take not one blood pressure or give her the rest of it. All painless, and she just pushed the morphine. You see how you got to put it all together? It doesn't change no matter what you do. If it's a painful procedure, you got to do what? Pre-medicate them. It's a given. That's the concept, okay? The next one is that I have circled is Acticote, I'm sorry. And if you look all the way over in the corner on the interventions, do not use with oil-based products or other topical antimicrobials. Why did I tell you to know that? Why is it so significant to know that? Tell me what you know about wound care, and I'll tell you why I want you to know that.
Antimicrobials are used to treat.
Do what?
Antimicrobials are used to treat a lot of wounds.
Yes, Acticos is used more than just for burns. We use it for decubitus. But why do I want you to know you don't use it with an oral base?
Like the whole tea.
Do what?
I mean, like a whole tea. Like it was, I don't know.
That's okay. You're shooting. That's all you have to do. The only way you're gonna learn is to shoot for it.
The cocaine, will the oil prevent it from absorb or something?
No, you're not putting it down the wound. Let me tell you why I told you that. When you were taught to do a packing in a wound, what do you put on the healthy tissue?
Normal saline.
The healthy tissue around it. The what? Yes. You were taught to put petroleum or something on the healthy skin to keep it from breaking down. Were you not told that? Mm-hmm. A lot of hospital policies, you put oil-based substance around it on the healthy tissue to keep the tissue from breaking down. Then you pack the wound and cover it. Now you will know when you use an Acticos, don't do that. If you don't know, you'll go ahead and put the oil base on there. That's the classical way to do a packing. Y'all don't remember working out. Some of y'all do. Some of y'all kind of stunned a little bit, but that's okay. If you didn't, that's fine. You're going to move forward anyway.
It just had like a skin barrier cream.
Yeah, but what's in it?
Yeah.
It's petroleum in it.
Yeah.
It's oil based. All of your wounds, they protect the healthy tissue with some type of ointment. That's what I'm telling you.
So if they're not using just petroleum, you have to make sure you read and see what's in it.
Most of your ointments are oil based. You cannot use it with this particular dressing. And they're used out there a lot, not just for burn wounds, but for other ones. Okay? What if you just put it on and you need to send the patient for an MRI? You do what? Take it off?
Can it burn them?
It's got silver in it.
Yeah, so it'll heat up.
So you see, of course, you got to organize it. If you know the patient is going for an MRI, you may want to delay the dressing change. That may be what ATR and NCLEX will tell you to do, okay? Because you don't want to cost effective by putting it on and taking it off, okay? But you got to know this particular cream has silver in it. You don't send it to an MRI.
So if it's actually in the wound, would you just rinse it with some saline?
Yes, that's what you have to do. I would not change it. I would just take it off, rinse it, put me a dry dressing on, send them to MRI, and change my dressing when they get back. That's what I would do. Yes.
I was reading the description. Is this like a patch? It's not like a cream?
What? The Acticos?
It says it's some kind of polyethylene mesh and single layer of something non-woven fabric of rayon. Does it like a kind of gauze or something?
Let me see if I can find it. Because we're talking about it.
because you use it on the moist and it's sterile.
Here it is. This is how you apply it, guys. I put it up there because it's fairly new. See? That's what the book is talking about. It's got a special gauze that you put on. It's got special wrappings that you put on. It's not like an ointment or gauze you slap on there. And in your hospital, they order Acticoat. You know it's an Acticoat kit. And you got to put the black one on, and silver is in all of this. So you see how MRI is not just an ointment that you put on. That was a good question. Okay.
Dr. J.
Uh-huh.
When we were in clinicals, they had a girl that had road rash from the back of her knee all the way to her foot.
Had what now?
It was like road rash, but when I say road rash, it was bad. But,
Really?
Like
Okay.
it was like these yellow things, kind of like this. Like, can you use it for more than just burns, or was it
For
something else?
burns? Yeah.
Okay.
Yeah, and we use it, it's one of the wound care treatment, period.
Okay.
But when you use it, you're gonna use it the same way, you got the same precautions, it doesn't matter, okay? Because that's one of the ones that you use for a lot of different things, even Civadine cream. Those little bio patch that you put on patients around their central line, guess what's in them? Sir. We use it all the time for wound. It keeps bacteria from growing. Okay? So a lot of stuff you're using out there has silver in it.
Would that be something we would need to remove as well, if they have a central line?
Now you know.
Yeah.
Now you know. But see, you just been putting it on, you hadn't thought about what's in it. What's in it. You know, it's got one side is like, look like that, and then you know your side. They go right in your central line. Some of them are chlorhexidine, and some of them have the silver. You gotta know what you're using out there and then what to do about it. Okay, but silver is a good substance to keep bacterial growth, so we use it a lot in practice. Okay, those were the ones that I had. The first one, Civadine. The second one, the third one, Sulfamalon. Then I have the Fosin, which is an antifungal.
Which one? The which one?
1, 2, 3, 4. The fourth one. 1, Civadine. The third one, Sulfamalon. And the next one is an antibacterial, I'm sorry, is nitrofloxacin. Okay. And then the Acticoat. The what?
The next to the last one.
The Furacin is the
The Acro, silver, all of those are silver-based medications.
It's the fourth one on 534.
Okay, thank you.
The Furacin,
And then she said one more.
Acticoat,
I'm looking at this chart.
There's just 4 on the chart?
I got the first one, the third one, 3, 4, the 5th, and the 7th. That's the ones I have circled.
So you're saying gentamicin?
The what?
You're saying gentamicin?
yeah, she said she just asked that.
I have it circled.
Gentamicin is circle.
Let me write them off on the board since there's so much dialogue, because I want all of us to be on the same page. Wouldn't that be the best thing to do?
Yes.
Silver. I do want you to pass this class now. They can really do. I say that, people don't believe me. I have nothing to gain or lose either way. You just gotta make sure you can prove what you say. Nothing else really matters past that. I do have the gentamicin, and I'll tell you why in just a little bit. And then the Acticoat. Okay. The other one is a silver. Somebody really worried about that one. So would you circle those in your book? Okay. Does that help? And start studying those or looking at them before you get back next week. Okay? The what?
I said quiz.
Maybe, maybe not. Maybe, maybe not. You guys all know you can't figure me out, right?
Right.
If you could figure me out, nursing would be boring to you.
We gotta try.
It's not gonna happen. I don't allow that to happen for one reason. Because you gotta be open-minded to anything happening when you get out into practice. It's not cut and dry. So I have to teach you that way, or be that way, right? Okay. The reason why I said gentamicin, and it was an ointment, see these drugs right here? These 3? They're on your slide. Those are for systemic infection. What is a systemic infection? How do you know when your patient has a systemic infection versus a local one? That's it. That's it. If they're running a fever with cellulitis, it's no longer just cellulitis. It's what? Systemic. Because you don't run a high fever or fever with a local infection. You may have a little low grade, but when you start 101, 102, 103, guess what? It is systemic, okay? So we do have to give patients systemic drugs for better burn. You already know this as seniors. This is a gimme. Like my colleague said, you're giving them those marks, aren't you? Yes, I am, because you already know them, okay? What do you know about vancomycin?
Ototoxic and nephro.
What do you know about vancomycin? Try to wake you up. Okay, let's go with her. She said peak and trough level before you give it.
We call red man syndrome,
Okay, red man syndrome,
ototoxicity and nephrotoxicity
Oto and nephro, why?
because it's aminoglycoside.
Good! What else? That is so great. Do what? Mixed with normal saline?
Over an hour.
You give it over an hour. Got to. What else do you know?
Are you saying the normal saline is incorrect?
No, I'm not saying it's incorrect, but you can also use D5W.
Antibiotic.
We usually put it in normal saline, but if you can. Do what? Well, watch your Davis book if you don't believe me. You just going by what you see in practice, and that's good, but add it to it. Okay, peak and trough, you gotta look. How many of you guys looked before you gave it in clinicals?
Yeah.
Good job. Okay, I won't ask you for those numbers because you won't remember. Red man syndrome. How do you prevent red man syndrome?
Slow it down.
Slow it down, okay? Because it comes from giving it what?
Too fast.
Too fast, good. Ototoxicity and nephrotoxicity.
Monitor the hearing kidney function.
So you actually did a hearing test while your patient was getting vancomycin.
Well, I didn't administer it, but
You actually checked the patient's hearing when you were giving vancomycin to the patient.
that's true. Yes, ma'am.
All right.
That's
You
what
talk-
Because if you're not meeting the standard of care for taking care of that patient. So all I want to hear is yes. Which one did you do? The Weber, the Renee, or the Whisper?
I whispered to him.
Okay. That's all I want to hear.
And then I watched their kidney function. You know, they had a catheter.
What did you watch?
I was making sure it was over 30.
What did you watch? Because I tell students, they'll tell me, Dr. January, I don't have a peak and trough level. Well, you're not going to have one if it was just started 24 hours ago. We got to wait long enough time before we do a peak and trough. Usually it's the third day or third dose. But then I asked them, what else did you look at? So you looked at the intake and output. See, I make you say safe in clinical. That's why students don't like me in clinical, but I don't care. I really don't. Because that's not what it's about. It's about you taking care of the patient safely. I'm going to teach you. I teach you something. Do what?
And the bone.
And, well, the BUN.
The creatinine is more specific, but you still watch them.
Yeah, you do. See, that's talking like a senior. You heard what he said? The BUN is not specific, but I still look at it. I know that the creatinine is specific to kidneys. That's what I want to hear. That's what I want to hear in clinicals. 2 people were talking about me earlier that had me in clinicals. I said, I appreciate it. Most of y'all have had me in clinicals. Yeah, not since 102. They don't know different.
Hey, she was bragging on me the other day about how much she felt better with herself since
That's the goal.
she had you.
That's the goal. Because you learn to put it together then. Clinicals is used to that. If you walk out there, you don't need your nerves.
No, I said,
Take the pressure.
no, I said it make you want to walk out, but you stay there.
Yeah, you say that.
You remember you walked out that room on me? made me shame in front of that lady.
No, you made yourself shame. I never say anything in front of her.
You told me off.
No, I didn't. You told me I did. Yes, digress.
You guilt nurse, you can go back to the lab.
Now, Quincy, you making that up.
She was in there. She was in there.
Just to make the patient laugh. The patient
That patient laugh. She felt my sorrow. But I bet you I know how to work it now. Connecting the IV line. And I wasn't pushing hard enough to, push and twist it now. She snatched that thing out my head.
Get it together. You know why I did that? You were in 201, wasn't you?
I think so.
Yeah. 201.
And then you told me one time, I'm gonna say this and let you go. You told me, she said, this is not the coincidence I know. You need to go somewhere and get yourself together.
That's it.
I said, okay, about 5 minutes, let me go sit down.
Because I wasn't seeing the performance, and I don't know what you wanted from me, but you're at 201. We only got 2 levels. And when you're not there, you need to decide why you're not there.
Mm-hmm.
And that's what I need you to do. Okay?
Bet you ain't saying nothing.
That's because I believe you have it in you.
You need to self-clean.
Yeah. Okay, cephalosporins, guys, is the last one. And those are your septins and stuff like that.
So we need to know those?
You already know about them. It causes pseudomembranous colitis, C. diff. They never got causing that.
And it's a GI tract, pretty much.
Yeah. You know what C. diff is.
Oh, yeah.
I haven't smelled it yet.
Oh, it doesn't smell good.
Yeah. It's so common. Did they stop the cephalosporins?
No, they were trying to figure out, she went from constipated, really constipated to just water. To just everywhere. But it was a little water was just so thick and so, I was like,
A lot of mucus in it.
yes, it was like puddled up.
Yeah. Pseudomembranous. That's why you know because it's very jelly-like.
Well, I had an 8-year-old that had it.
Really?
They didn't know why though.
Sometimes things happen, guys, but you know that will occur from your cephalosporins more so than any type. Okay.
But
And
she
I'm
wasn't
just
on
giving
any.
little snippets.
She wasn't on any antibiotics, I could say.
Maybe she got contaminated. It's highly contagious. She was in the hospital, a nurse could have given it to her from another patient. It was okay, let's move on, guys. And then I'll give you a quick break. I hope that guy gets here soon. The other medications, you got a handle on it now. You're learning what I want you to know as far as the medications. What you already know about vancomycin. Got it? Okay. There's one thing that you may or may not know about vancomycin, and I'm going to give that to you. You have it's a lot of vanc, isn't it? Let's drop it down to 1 gram. No, let me do 1.5 grams of vancomycin. What's the minimum amount of IV fluids that you mix it in?
300.
What's the minimum amount? Some of y'all know it because you kind of did it before, but hold that thought. What's the minimum amount? You know, I had a student that I could have failed in clinicals, and let me tell you why. Because she went on and hung it in the wrong amount of fluids because a nurse told her to do it. And pharmacy was so upset. And I just kind of like, okay, you won't do that again. But the only thing that really saved her is the patient had a central venous line in. Because we can give it peripheral, right? Yeah, you can, but make sure your needle is very, very small that you put in, like a 22. I don't care if they got a big vein. You put in a 22. Why? That's standards. You can Google that. When you got in a 22, you got blood turbines around it. If you jam a big needle in a vein to give vancomycin, you're going to eat the vein up because you got little blood turbines past that needle. So the premises is you put in a smaller needle that the vein can accommodate. So you can have blood coming around that needle. The ideal method is to put it in what? A central line. That's the ideal method, is to have a central line in. But not all patients have a central line that's getting vancomycin. So when you go and start the IV, one student saw that. She said, Dr. January, patient had a 20 in one arm, and she said the nurse put a 22 on the other side and gave her vancomycin in that one. And I said to her, why did the nurse do that? Well, she didn't know. The nurse couldn't really explain it to her except she was following protocol. Now, why did the nurse do that?
Blood turbulence, not deep.
It's the standard of practice for vancomycin. Okay? So, get back to this. Student hung hers at 100 milliliters. She had one gram though. I'm giving you 1.5. What is the minimum amount of fluids you should put that vancomycin in? Have you guys heard of vancomycin? How much fluid was it in? Just remember, just recall. It was what? I'm sorry, I can't think. It was 100. It was what? You gave what?
Half a gram and 100 milliliters.
You had that?
500 milligrams.
35.
You had 500 milligrams?
So you have to half a gram.
And you had it at 100. Who fixed that up for you?
No, 250.
Stop right there. Anybody else, can y'all remember?
I remember it was 250.
You remember 250?
I think so. It was in a small, I remember the date, I think it was 250. Yeah.
Okay. How much should this be if you're answering him? 300. She was right. It probably was in 100. Because for every 500 milligrams, it has to be in 100 milliliters. So both, you're right, and she was right when you hung it, but you were like, I know it was in 100, but I don't want to say because I may have messed up now. Get in. 500 milligrams. Every 500 milligrams has to be in 100 milliliters. I'm not making that up. Read it in Davis. That's why you see pharmacy sending that gram in 200 milliliters. And that student should have known that. But like I said, the only thing that saved her, I said, now what is the worst that can happen? You know when you mess up on me, that's what I tell you. What is the worst that can happen to the patient? And what is the least that can happen? And one is going to outweigh the other. Because that patient had a central line in, I wasn't scared. She ran it over 60 minutes. It still should have been what? Diluted more. You agree?
Yes.
1,000 milligrams in a 100 milliliter bag? It should have been in what? 200. But the nurse mixed it on the floor, and that's what she put it in. And gave it to the student hang. And I allowed her to call pharmacy. Because I wanted her to see the end product of what happens. And pharmacy was upset.
Will they have to do it as an incident report? Does it break standard of
We did, it's supposed to be an incident report. Let me tell you how it went. I told the charge nurse what happened. And I said, you want us to do an incident report? She said no. Now, I went with it because it was given through that. Okay. All right, so the next thing is the other medicine on page 517 that you have to know. And we're going to get into treating this burn patient in just a little bit. But I want you to go home and learn these medications. Yeah, I want to show you why you give these. They'll talk about it, but I want to show you why. If you don't know why you're giving something, you're not going to learn. Okay? On all your burn patients, they will develop something called what?
Curling ulcer.
Curling's ulcer. Now let me tell you guys something. Anytime you have a patient who's critically ill, under a lot of stress, they are going to produce a lot of hydrochloric acid, right? And you're going to have some tumor. They can get ulcers. I've had heart attacks start vomiting blood. They came in with a heart attack. Now they got a GI bleed. What happened? Too much stress. So now, haven't you noticed every patient in the hospital you gave them Protonix? Yes. What else you gave them? What? Carafate. What else? They didn't have histories of ulcers, but every one of them got one of those H2 blockers or proton pump inhibitor or something. Every patient you took care of got one of those with no history of ulcers. Why do they get it?
To prevent
prophylactically, because patients under stress will develop ulcers. Now, burn patients, because of Dr. Curlins, thought he was doing something to discover it, you named it, but it's a stress ulcer that occurs in burn patients. So you'll see them getting H2 blockers, Xanax, something like that. Proton pump, Protonix, one of those. Okay? And see, that's why they don't like me in 201, because I teach you just like your seniors, except for you only have one patient. There's no difference. Once you hit 201, 202, and 203, they're the same. You just increase your patients at 203. You should be at the same performance. Does that make sense? Mm-hmm. All we should do is increase the number of patients when you get to 203. That's it. And I put a note, need HCl to create a barrier with Carafate. Okay. What is the number one side effect of Carafate? You said you didn't. First of all, what does Carafate do? It coats the stomach. It's not absorbed. It coats the stomach. So what's the number one side effect of Carafate? What is it? Constipation. That's it. That's it. And that's the kind of stuff I test you on with medication because you've already got it. I just did a little snippet of it, so you go back to it. Okay. Burns are very, very devastating. So what I'm going to do is let you take 10 minutes, rest your mind, and we're going to get into the pathophysiology and what we got to do for burn patients.
How do you spell that? Carol. C-A-R-O-L-A. Okay, That's yours? Boom, yes. Okay.
The film actually showed a lot what I wanted to show with the severity, the depth, and location. But I wanted first the little picture that I gave you. I want you to look at that. It looks like this. Okay? And I just want to talk to you about the stages of treatment. Anytime you have a major burn, and your book says less than 25% inflammatory degree, okay, the patient will have a systemic effect.
So major burns are classified by greater than?
That's a greater than sign.
You said less than.
Okay, greater than 25. See, I can't do but one thing at a time. We need to wait for those pens. Systemic effect. Because he's gonna wait for me, so then go out by again. This little chart is indicating what happens, okay? If you look at the top one, is what happens with the normal capillary. Whenever you have a systemic effect from burns, you have enzymes that are released throughout the whole body. And what it does is cause the blood vessels, the capillaries, to leak out more. What it does is change the permeability of the capillaries. Got it? One of your colleagues was sharing how her dad had swelling all over. And that's what happens because they leak fluid all over, and they leak it very, very rapidly. Okay? Very rapidly. It's not a slow process. It's like minutes. Okay? So whenever you're looking at this with a major burn, because of enzymes and all and cytokines that are released with the burn, it causes your membranes, your capillary to open up to things. So fluid starts to leak out. What else leaks out?
Protein.
Protein?
Electrolytes.
Electrolytes? Which one? Sodium? Now this is the capillary. So it's leaking out of the capillary. What else leaks out? Water. Water. And you know blood water is called what? Plasma. Those three things are going to leak out. Got it? Those three things are going to leak out a patient who has a major burn that has become systemic. So what's going to happen to the patient? And this is how my test questions go. It's on page 516 that's showing the same picture that I gave you. Okay? But if you kind of read over that, you're going to miss it. So before we start treating this patient, I want you to see what happens. I give you lab works on your burn test. Okay? So let me ask you this. When we draw blood, because sometimes I have to put you guys back in what's going on. When we draw blood, we draw it from what? A vein. So we draw blood from here. Okay? With that being said, what do you expect for the patient's albumin level to be?
Low.
The what?
Low.
Low. What do you expect for the patient's sodium level to be?
Low.
Okay. What would you expect for the potassium level to be? As sodium goes down, what goes up? Potassium. You can remember it that way. Plus, you got so much cellular damage. Anytime you got a lot of cellular damage, you're going to have a patient with an elevated potassium. Got it? I've seen bad car wrecks that ended up on dialysis, not because the kidneys went out, but because they had so much potassium in their bodies. We had to dialyze it out because of the massive tissue damage. Okay? What happens to the H&H? Goes what? Goes up. Why? The what? Now I want her to answer.
It's
Why?
going to be concentrated, there's not going to be a lot of fluid. Fluid loss is going to make it, the blood more compacted.
Okay, so you're losing plasma, the water out of the blood is called hemoconcentration. So it looks like the H&H is high. So when I give you a test question that is low, what's the problem? What's the problem? It's not supposed to be low initially in a burn patient.
You got bleeding.
Something is wrong other than that. Like the film said, burns doesn't cause the patient to be unconscious. You got a burn patient coming in who's unconscious. The patient is telling you something else is wrong with me, which may be what? A head injury. So just like that, if the H&H is normal or low, then something else is going on. They may have internal trauma that's bleeding out. Because burns won't do that. The H&H will be hot. Does that make sense?
What did you call it? What was the word you used?
Hemoconcentration. Yeah. That's what Potter Perry calls it. That's what I call it too. Okay? So that's the hallmark for taking care of burn patient. And let me give you this, and then I'm probably gonna give you a break and let you go order your pens or do whatever because it's 4 o'clock. Okay, and I got to a lot of this. And I'm going to see why you think I should or should not have had a Tourette syndrome that night. Now, when they lose this right here, they're going to lose the blood pressure. It's called what? Burn shock. Okay? That's what it's called. And we're going to talk about the depth of burns and all of that, but this is what you really need to nail. There's 3 phases, and you want the patients to go through these phases. Okay? Burn shock. Because they're losing what? Fluid. Now, I worked with a nurse who went in and turned my IV fluids down on my burn patient. Okay? And by the time, like, she told me what she did, she came up and said, I turned out, at that time we had the patient there at the hospital, and his whole, I can remember his chest and his arm was swollen, okay? With burn, I mean a bad burn. So that constituted close to 25%, so he became what? Systemic. He was losing fluid, I mean, the fluid was everywhere. It'll leak from everywhere. And she went in and turned my IV fluid down. Why did she turn him down?
She saw the swelling and
The what? She didn't know any better. Bottom line is, she didn't have the knowledge to know what she's doing, period. You can make up any excuses you want. And she didn't know that she should have left those fluids running. I had already lost that patient's blood pressure by the time I got down the hall to check on her. I had already lost his blood pressure. And it was good, like 120, 180, and I was down to like 70. By the time I got down there and checked it, it was less than. Now I have to remember, she may have not come directly to me and told me she turned it down. She could have went and did something else and then came. But by the time I got down there, I had no more blood pressure. Okay? Is that scary? Fluid resuscitation is so important. That's why I want you to read that first stage, the emergent phase. Okay? And on page 527, 526, the film told you what you needed to do. Okay? See on page 526? This is what we do. ABCs and fluid resuscitation for the burn victim. It says rapid infusion of IV fluid known as fluid resuscitation. Okay? It has to be done. See the little formulas in the box? See the fluids in the box? Okay. I want you guys to come up and get a calculator. We're going to go ahead and start with that, because that may be one of your test questions.
Thank you.
If I start you off with stuff that you need to pass the test, you'll be okay.
Yes, thank you.
Yeah. She brought some good
Dr. J, did you say there was a page for the phases?
The what?
Is there a certain page to refer to for the phases?
The phases, I put them on the PowerPoint.
Okay.
Where we're going now is the emergent phase, and I just want you to start, see right here, phases of burn care. The first one is resuscitate. That's where we are right now. I want you to go ahead and start learning that.
What page was it, Dr.
520 starts the resuscitation phase. But I want you to go ahead and start learning the fluid ones.
Everyone have a calculator, sir?
Okay. Let me go ahead and do this, and then, because everybody want to do their pens, and I'm going to give the guy the opportunity to do it, okay? If you learn fluid resuscitation, there's a lot of it on my burn test. You got it? Because it will keep your patient alive. It is the resuscitated stage, what we call the emergent stage or emergency stage. Just think about it that way. it is very, very salient to a major burn. You're going to lose the patient if you don't, because they're going to burn shock. Got it? So that patient, and I'm using that patient as an example, because it actually, and I had one student say, Dr. January, I wouldn't have believed it, that it happened so fast. They saw a burn patient in the ER and they went through it. It happens really quickly, guys. Okay, so you start your 2 large bore catheters in each AC, because you got a major burn. What type of fluids are you going to have ready? That's it. Got that from the film, right? That's what you have ready. Okay. Now calculate how much fluids I'm going to give to this patient in the first 8 hours, and that's what the film was talking about. 25% burn. Second and third degree. He weighs 75 kilograms. He got burned at, what time is it? At 2 p.m. Okay? And what I want you to use is the Parkland-Baxter's formula. That's what's on my test. On page 526. Don't worry about that. Figure out the total amount first. 4 milliliters per kilogram times the percentage of total body surface burned. So how much? 7,500 milliliters of IV fluids in 24 hours is what's needed. See why I got so angry? And had Tourette syndrome?
That's why you almost had Tourette.
I did have one on her. Because she created a problem for me. Now I got to work to get this patient's blood pressure back up. Okay, now what you do with the 7,500, you got to give half of it in the first 8 hours. So what's half of that? What is it? $37.50. In the first 8 hours. And it doesn't matter what, you got to count it from the time that he got the injury. So he was injured at 2 p.m. When do we get the first 8 hours in? He was, because you got to count it from the time that he had the injury. Not now. Okay, so you count it from the time of injury. If he waited and came in 6 hours later, if it happened at 2, took them 6 hours to get him there, we still got to get the fluids in at the time of the injury. You count the 8 hours from that. Got it? That's what the book says. You can read it there. And that's what the pen says. So what time do we have to get the 3,700 in? 10 o'clock from 2 to 10? Okay, so how many milliliters an hour? 400 what? 69. You see why I got angry? She cut my IV fluids down to almost a KBO rate. Because she didn't understand that. She thought it was going too fast. Mrs. Stevens gave me. I got tired of changing that bag. See how fast she would have changed the bag? She said that she thought it was going too fast. Lack of knowledge. Okay? And it really kind of made me angry because then I had extra work to do in the middle of the night to keep his blood pressure up.
Dr. Jane, how do you approach it if they don't know a time?
Huh?
How do you approach it if they don't know the time?
You have to kind of estimate. Somebody should know.
Somebody.
If you don't know exact time, it happened around 12 noon. We go with that. But it starts from the time of the accident. Okay. That's how we do fluid resuscitation because of burn shock. You will lose the blood pressure. And I'm going to stop at that point because some people are more focused on ordering these pens. I want you to be nice and pretty in your pen. Crystal laughing. And I do. So it's going to yield some
why I had to start typing, but I couldn't.